Assalamu alaikum, all of you. Ji. Ji. Um, we will begin our today's session with the name of Allah. I welcome you all on the annual scientific session of Fatma Jinnah Medical University 2023, and this is the session on reproductive health. I would like to call upon Dr. Abdur Rahman for recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله
Jazakallah. I would like to call upon our chairs of today's session. First of all, for our chief guest, Professor Shamsa Hamayi. Kindly welcome. She is an academic advisor, Department of Medical Education at College of Physicians and Surgeons of Pakistan, former Vice Chancellor and former Pro Vice Chancellor. She also served as the head of Department of Gynae and Obstetrics. So, Madam, I welcome you. For Fatma Jinnah Medical University Chair, I would like to call upon Professor Noreen Akmal. She is Principal Fatma Jinnah Medical College, and she is a Director of Medical Education, done Masters in Maternal Fetal Medicine from University of Barcelona, Spain. Next, I would like to call upon for the student chair, Dr. Muqaddas. She is the CR of final year. And for the Chemka UK chair, I would like to call upon Dr. Ambreen Sajjad. I will call our first speaker, which is Professor Alia Bashir. She will talk about the menopause and its health challenges. So, very welcome, please. Can you see?
इंट्रो स्टार्ट कर
इंट्रो मेरी सारी स्लाइड पे लगी हुई I would first of all like to thank the organizer of this symposium, and they have given me the opportunity to talk at this forum. I myself is a FJ graduate, therefore it's always a very good feeling whenever I am coming back to this prestigious institute and to talk to these girls. कभी याद आता है कि हम भी यहाँ बैठा करते थे और अपने टीचर्स को सुना करते थे. So it's always good to be here at Fatma Jinnah Medical University. The topic that I'm going to discuss is that menopause and health challenges. Menopause is been taken as like something which is been neglected by the society as well as by the health physicians. लोगों को ये लगता है कि मीनोपॉज हो गया और मीनोपॉज बस इज समथिंग लाइक कि फीमेल ने इसमें से गुजरना है एंड दिस इज जस्ट अ मेयर डेफिशिएंसी ऑफ हार्मोन और इसके बाद इसको हार्मोन की डेफिशिएंसी और इसने होना ही था एंड देयरफॉर इट इज बीन लाइक दैट बट इट इज द कॉज स्टेट लाइक दैट अबाउट 50% फीमेल्स जो हैं वो पास करती हैं थ्रू द ट्रांजिशन ऑफ द मीनोपॉज एंड द मीनोपॉज इज अ स्टेट विच has to be passed through many of the females because of the increase in the life expectancy. Ab females ki jo average age it has been increased like up to 70 or 75 years of age. So 1/3 of the life has been passed through the phase of the menopause. So it's very important कि हम menopause को देखें, उसको address करें, and we should bring the public awareness among the not only among the healthcare professionals but also among the general public, so that they can seek the advice at the earlier stage. And they can prevent the consequences of the menopause that can be later on detrimental to the life of the female. So if we define as what is menopause, तो कौन सा कोई बच्चा बताना चाहेगा? I have 20 minutes, so I can ask 1 or 2 questions. वैसे definition दिया. Final year आ गई. किसी को नहीं पता? कोई बच्चा? Okay, fine. The menopause is defined as if there is a permanent cessation of the menses for at least 12 months from the last menstrual cycle. And its median age is 51.4. हमारे यहाँ पे पाकिस्तान में तकरीबन 51.4 है, लेकिन अगर the females have start getting the menopause before the age of 40 years, then it is an abnormal and it is called the premature menopause. और वही जो अभी हमने बात की कि लाइफ एक्सपेक्टेंसी बढ़ चुकी है, therefore the one third of the life of the female has been passed through the age of the menopause. So menopause is not something a disease, it's just a transitional phase from which the woman is passing from the reproductive to the non-reproductive stage because of the lack of the hormones produced by the ovaries. और ये एक abrupt change नहीं है, it's a gradual change that occur over the years or maybe over the months. And the stages जो कि आप जिसमें देखें मिनार्की के स्टेज पे होती है बच्चों, इतना तो बता दो, 13 ऑलमोस्ट ईयर पे. फिर रिप्रोडक्टिव एज कब से कब तक आप कंसिडर करते हो? अप टिल 40 इयर्स ऑफ एज. फिर 40 इयर्स के ऊपर आपका पेरीमेनोपॉजल एज स्टार्ट हो जाती है एंड देन फ्रॉम द 50 years onward that it is become the menopause, and mostly the females at the around 51 year of age ended up in the menopause. So it is because of the lack of the estrogen hormones produced by the ovaries, क्योंकि ovaries की aging हो जाती है, hormone production कम होगी, and then there will be negative feedback जो कि FSH पे there will be no more there, and there will be increased release of the FSH from the anterior pituitary, and this is simply the hormonal plays that occur behind the menopause. In addition to the natural cessation of the menstruation, there are certain other risk factors that can lead to the menopause, जो कि आपके सर्जिकल मीनोपॉज हो सकते हैं. सर्जिकल मीनोपॉज कहाँ होता है? हिस्टेक्टमी होगी. Sometimes the radiation can be given due to certain reasons, or some other disease, chemotherapy due to some ovarian disease, cancer. Sometimes this smoking, alcohol, caffeine, and sometimes history of premature menopause runs in the family at times. And there are certain drugs that are also associated with the menopause, like gonadotropin releasing hormones, for therefore if they have been used for the longer period of time, or anti-estrogens like clomiphene citrate, if they have been given a prolonged period of time, they can lead to the decline in the ovarian functions. Therefore it is very important कि हमने जो भी medicine जब भी देनी है, we should give them cautiously and carefully. एंड मीनोपॉज आपका 3 टाइप तरीके से हो सकता है. कहीं सडन सेसेशन जैसे सर्जिकल केस में होगी, otherwise there is a gradual decline in the amount of the blood loss that has been maybe over the months or over the years, and sometimes there is a gradual increase in the spacing of the periods, like patients को maybe 2 months बाद, 3 months बाद, and gradually there is going increasing the period or spacing in between, and then they can end up in the menopause. अगर अब मीनोपॉज हो गया तो क्या साइन एंड सिम्टम्स हो गए? आपके ख्याल में पेशेंट्स किस तरह से प्रेजेंट कर रहे होंगे? हॉट फ्लैशेस वेरी कॉमन, एंड मूड चेंजेस, और वीक बोन्स, हेडेक्स, पैनिक अटैक्स, मूड स्विंग्स, insomnia, irritability, difficulty with concentration, ये सारे के सारे poor short term memories, they can all be the signs and symptoms of the patient who has suffering from the menopause. And there are some medium term symptoms like vaginal dryness हो सकती है, dyspnea हो सकता है, frequency of micturition हो सकती है, urethral syndrome जिसको हम कह सकते हैं, thinning हो सकती है, skin collagen tissue का loss हो सकता है. They can all be the midterm. And then the long-term symptoms can be cardiovascular symptoms, osteoporosis, cerebral vascular disease, and the membrane loss can be memory loss can be the long-term consequences of that. In addition to these all signs and symptoms, there are certain psychological manifestations of that. That can be the patient feel irritable, mood swings, reduced motivation, loss of libido, anxious, panic attacks. They feel low self-esteem. They are all can be psychosocial symptoms associated with it. Once the menopause occurs, how we can make it that diagnosis? We can make it diagnosis if there is a 12 consecutive month cessation of the periods for after the last menstrual period, or if the patient is a younger age, less than 40 year of age, and if they have the FSH of more than 30 international units per liter, then we can say that the patient is suffering from the menopause. So if we, once the patient has suffered from the menopause, or There are different choices that are available for the female, and they have the right to pick and choose those choices so that they can, the consequences of the menopause can be prevented. So there are four options. Either they can go naturally, whatever the nature has done to them, they continue with that and they don't seek any medical advice. Or sometimes they can use start supplements, vitamins, neuropathics, and homeopathic remedies. And sometimes there are medical treatments to for the symptomatic relief of the sign and symptoms that are occurring due to the menopause, and then the hormonal treatment that whatever the deficiency is occurring there, we need to replace that one. So, if we talk about this hormonal treatment, that the hormone replacement therapy is one of the mainstay that is coming up with, and almost not all the females need the hormonal replacement therapy, but 70 to 85% needs only good nutrition, healthy lifestyle, and some may need the hormonal replacement therapy as well. हमने कहाँ देनी है, very important, not to every patient, where they have a sign and symptoms of climatic symptoms, vasomotor, urinary symptoms, sexual disharmony, or there is decreased bone mineral density or osteoporosis. These are the patients we need to give, but we have to weigh the risk versus benefit of hormone replacement therapy. There are different types of hormonal replacement therapies available. They can be estrogens only, they can be progestrogens only, and they can be combined as well. And they can be given through different routes like transdermal pads, subcutaneous implants, depot injections, intrauterine, oral, and sometimes local applications are available. So, if we look at why we are talking about hormone replacement therapy, because of the deficiency of estrogens, and whatever the consequences occur due to the estrogen deficiency, they can be addressed by giving the hormone replacement therapy. So their benefits is that they alleviate the vasomotor symptoms, or they improve that. They improve the mood swing, sleep disturbances, and other social factors that are associated with menopause. They can improve the urogenital syndrome and improve the quality of life. They improve the connective tissue, therefore, they prevent the intervertebral disc thinning. They increase the collagen strength, and therefore avoid the skin wrinkling and the aging effects of the skin, and they can also prevent the cartilage loss. Colorectal cancers, different studies have shown that they are found to be beneficial and they reduces the risk of the colorectal cancer. Similarly, the studies has coming up with the promising effect of that if HRT is being given at a time, they can avoid against the cardiovascular disease, but the results of studies are conflicting. Some says that it avoids this, and some says it slightly increase the risk of stroke and cardiovascular disease. Dementia and cognition again can be improved if they have been given in the right time in the right person, and but again need to be selected whether it is to be given or not. And then there are certain other synthetic hormone replacement therapies like Tibolon, which has estrogenic, androgenic, and progesterogenic effect, and it is found to be have a beneficial effect similar to that of the hormone replacement therapy. Then there are certain local estrogens, creams, vaginal pastries that is available and that can be used, and they have a beneficial effect, and they don't have the systemic effect. Therefore, they can be given in those patients in which the oral medications are contraindicated. So, if once it is to be stopped, how to stop? Whether we should stop it abruptly, the answer is no. We have to taper the taper the dose accordingly, and then, or either we have to decrease the estrogen in that, so that the patient shouldn't have immediately. अगर हम उसको immediately stop कर देंगे, the patient will again have the sign and symptoms. So उसको आप taper करें. अगर आप 1 daily दे रहे थे, तो फिर आप उसके बाद 2 to 3 times a week कर दें, फिर उसके बाद gradually 1 or 2 weeks a month कर दें, and then gradually you have to taper and then stop the medication. There are certain alternatives that are available to the hormone replacement therapy, and they can be given to the patients whom the HRT is contraindicated. These are the some specific estrogen receptor modulators. Tamoxifen is one of that. It has a beneficial effect on bone, cardiovascular system, but on the same time it lead to the uterine endometrial hyperplasia and is a risk factor for the endometrial CA. They have to be given in caution with those patients who have risk factors for the endometrial CA. Then is the raloxifene, another. This reduces the risk of fracture by 50% and causes the 10% reduction in total cholesterol and low density lipoproteins and high density lipoprotein level. They are found to be cardioprotective because they decreases the level of the triglycerides, and they also help in improving the bone health, avoid the osteoporosis, and they decreases the risk of the breast cancer by 65 to 70%. Phytoestrogens are another options that are available in our natural foods and food products. Therefore, they are found to be also beneficial, and they also improve the menopausal symptoms, chronic heart disease, osteoporosis, and cancer of the breast, colon, and endometrium. बस आखिरी दो लाइन. Bisphosphonates are another alternate, and they are helpful in avoiding the osteoporosis. So the recommendation is that hormone replacement therapy is not only the treatment option. In addition to that, we have to advise the patient regarding their healthy lifestyle and their physiotherapies. And it has been recommended that HRT should not be recommended without a clear indication, that is, if there is a significant sign and symptoms, or HRT is not a single regime, the other standard treatments should also be taken care of and should be considered, and they should be given for a shorter possible time to just to alleviate the symptom, not for as a long term therapy. Thank you so much.
Thank you so much for such an important topic. Dr. Alia, they say that women usually, due to the increased life expectancy, one third of her life is just spent in menopause. So this aspect should never be ignored. Now, I would like a very learned professor, Professor Rubina Suhail. She was the professor of obstetrics and gynecology at Services Hospital and currently working at Hamid Latif Hospital. More than 25 years of teaching experience. She is a champion of sexual and reproductive health and women rights. She is the pioneer of kangaroo mother care, served as a president of SAFOC, and so many to go on. So kindly welcome Professor Rubina Suhail.
Bismillahirrahmanirrahim. Thank you very much for inviting me over here to give a presentation actually on a very important topic which is very close to my heart. And I see that a lot of medical students are sitting over here and senior doctors. So I think that it's an important topic for each one of us. And I'm glad that Dr. Tayyib is over here because he's the sole male person representing the male community of OBGYN. So the topic that has been allocated to me today by Dr. Aisha is violence against doctors, and I will take 20 minutes. So मुझे 15 मिनट के बाद बेशक remind करवा दें, उससे पहले ना कराइएगा. There's no conflict of interest to disclose, and I would just like to acknowledge Professor Farooq Suman and Dr. Ann Kehara for the support that they provided to me in preparing this. I'll just start with a tragedy. And violence against doctors to me is a tragedy. And we are all most of us are living in Lahore, and we are all familiar with this case. And this was the tragic incident which happened in Children's Hospital in the earlier part of this year. He was a young doctor working in emergency. He was to be married in 4 days' time. And after the violent incident which happened, in which the child's family beat him up so badly that he ended up in the ICU of a hospital. 4 days to go to get married and you are in an ICU. I think there could be no more bigger atrocity to a doctor than having them lose their self-respect. And just a small thing that I would like to show to you. And to me, this is a sign that how people make us lose our self-respect. Look at the doctor in a normal situation and look at him now. How much dejected and depressed he is, and how difficult the period of recovery would have been for him. We can only imagine. And I actually wanted to go and meet him, but I could not, because I thought that there were so many people who were meeting him for political reasons. It would not be supportive for him to talk to me as well. But this is the fact of the situation. Now, the important thing is that many a times arguments are taking place in our outpatient departments. Arguments are taking place outside the theatres, outside the labor rooms. And seldom do the young doctors, especially because young doctors are the brunt of this situation more than the senior doctors, because they are the ones who are manning the emergencies of the government hospitals, who are there as the first responders. So the issue is that they are also not aware how quickly a situation in which there is verbal argument or there is verbal abuse, how quickly it can convert into a physical situation. And that is why I thought that it is very important to discuss. And the third party, which is the relatives of the patient, make no effort to stop the situation. No elder, we believe in elders, we are a social system जहाँ हम economies of elders की बात करते हैं, जहाँ community की बात करते हैं. But in this kind of situation, no elder would come and stop and say, don't behave like this. This is a person who needs to be respected. And that is why I think this issue is so important. Now, WHO has laid a lot of importance on these kind of situations. And as early as 2002, when the situation was not bad in South Asia, probably, they said that workplace violence, they defined workplace violence as a situation where the staff was ill-treated, intimidated, or attacked in conditions which were linked to their workplace, including commuting to and from the workplace, involving an explicit or implicit challenge to their safety, well-being, or health. So I think it is important to realize that the WHO is also aware of the grave situation. Now, this is a Medscape article of as early as February this year, which says that nearly 9 out of 10 physicians have reported in recent Medscape poll that they had experience of one or more violent or potentially violent incidents. And that brings me to all of you, the senior people who are sitting over here. How many can say that they went through a violent incident? And I am the first one who will raise my hand because I did. And I don't know how many of you did. But in the Medscape poll, 9 out of 10 healthcare providers said that they had faced such incidents, and the most common behaviors were verbal abuse, getting angry and leaving. But it is more than that. The physical abuse part becomes grave. This is a study about the magnitude and the determinants of violence against the healthcare providers in Pakistan, which was published in the BMJ in April 2020. And according to this, and this is a huge study because it was conducted in 4 large cities in 12 districts in 3 provinces of Pakistan. So, giving us a good number of 8,579 healthcare providers of all cadres. And what were the results? The results showed that about 38.4% of the healthcare providers reported incidents of violence happening to them. Most of the violence was verbal. Don't take it lightly. Verbal violence should also not be allowed. But there were about 6.6% of physical violence as well. And I always try to extrapolate the Pakistan population with the incidence of violence. So when you look at 6%, आप कहेंगे 6% ही तो थे, ये तो कोई खास नहीं थे. But वो खास थे because when you convert that 6% into the number of doctors that would have been affected, it is huge. Every day we are listening to news reports about incidents of violence happening in various places. Now, according to this study, what were the reasons for the violence? So, death of the patient. So, if the patient dies, it is not God's predetermination, it is always the doctor's fault. Serious condition of the patient. If you have a serious patient coming into your emergency, you must think about violence. You must be careful about how you are dealing with that patient. So 16% and 13% of violence was because they perceived that there was a delay in care. So these are the reasons that what happened in Pakistan. It is the same all over South Asia. So in India, it is almost an epidemic proportion of violence against doctors, and they use the term that the fear is palpable. The fear is palpable amongst the healthcare community. So many incidents are happening, and they're running a very good campaign against violence against doctors. In Bangladesh, the situation is the same. And according to their studies, the maximum events happen at the night time when security is poor, when doctors are less in number, and when the administrative support staff is probably not there. Most of it again happened in government hospitals, and in their cases, most of it was in happening to male doctors. But this is not true all over the place because in Pakistan, statistics might be a little bit different, so females are also as much affected as the males. And the perceived reasons were again the same, the delay in treatment and the political thing, like if you are related to somebody, you have some power, you will come in early in the waiting room and go to the doctor first, and death declaration was another issue. The same situation in Nepal, and the same situation has been seen in UK, where in UK GP surgeries, the criminal acts of violence have almost doubled in 5 years. So it is not an issue only of poor countries, only of low-income countries, only of uneducated, poverty-ridden countries, but it is an issue of the Western world as well. and the GPs have got appalling tales of violence to tell of what is happening over there. And so is the case with the United States of America. So the incidence has grown by almost 67% by 2018, and there are still figures which this came out in 22. So the incidence, and the American College has shown that more than 3,500 ER doctors were attacked, and 47% were assaulted, and 97% of the time it was the patient himself or herself who attacked the healthcare provider. Similarly, in China, deaths have been reported because of violence against the doctors. A doctor was stabbed to death in 2018 in one of the hospitals because they thought that the doctor had not provided enough appropriate treatment to his wife. So this is the situation, and I would just like to share with you because it seems all rather recent. And I'm sharing with you a paragraph actually from one of the articles which was published 135 years ago. And what does it say? It says that no physician, however conscientious or careful, can tell what day or hour he may not be an object of some undeserved attack, malicious accusation, blackmail, and sued for damages. So this is happening from a very long time. Now, what is the fact of how healthcare provider situation in South Asia? And there's a lot of things that I want to say, but I would just like to hurry over here. We have got prolonged working hours. I know CPSP has done a lot to reduce the number of working hours, but still the number of working hours are quite a bit. Night duties are there, there's lack of sleep, there's stress related to work, lack of trust between the patients and the families, lack of healthcare facilities at work, not appropriate facilities available, and most of the things which are not there in the hospitals, the doctors are blamed for that. And administration very rarely comes forward. Poor pay structures, poor work-life balance, and frustration. So this is happening not only in Pakistan but almost all over Asia. But I would also like to say it is also happening in UK. So I was giving my presentation the day I presented. Part of this presentation was presented at the RCOG during a plenary talk that I gave in London. And the same day there was a doctor strike. And so the things are not good even in UK and other countries. Now we would like to look at the reasons that why is this happening and what are the steps that we can do to protect our doctors. I think this is a topic of immense importance, and the kind of weightage that it needs, probably we are not giving it even now. So why does it happen? The usual things are that the patients are not well educated, they are not aware, their communication and information is poor. And many a times the doctors are directly blamed for their attitudes, they are blamed for inadequate communication skills, for lack of apathy, for lack of preparedness to deal with such situations. But having laid out both the partners in the game, I would just like to say that the most important factor in this situation is the health system. The health system is not prepared. There is not an adequate health system. So what's happening with us? Lack of adequate health system, long waiting hours and queues for the patients, poor standard waiting areas, and you can go in any government hospital and you can confirm this that this is happening. Communication gap, poor labor room, AE and ICU facilities, cost of healthcare sometimes that the people have to pay thinking that they're going to hospitals where there will be less amount of money. You know, in a private hospital, when a patient comes, they think they're doing you a favor by paying the amount of money that they're paying. And they think that because they're paying that money, now they can treat the doctor as badly or as adversely as they would want to treat. So these things are all important. And then also that we do not have facilities to tackle with the grievances of the patient, and we use power practice. So अगर मेरा रिश्तेदार है हॉस्पिटल के किसी भी एम्प्लॉय का रिश्तेदार है, सबसे पहले वो आएगा. इसका मतलब ये है कि कॉमन पैन विल बी द लास्ट to be addressed and will be taken care of. So इसको भी देखने की ज़रूरत है. But what is happening actually amongst the patient's families? They perceive that we are not just, we do not satisfy the patient and their families, we do not give them enough attention. Because they are under stress, they think it is a right to misbehave, and they perceive that there is a medical negligence. And the information department, the journalists have got a lot to do for that. This is a very favorite statement of mine, and it is not mine actually, it is somebody else's, and it was one of the justices who said that justice must be seen to be done. So when we are treating a patient, Dr. Ashim मेरे उस्ताद हैं, वो कहते थे अगर सोते हुए बच्चे ना तुसी मुंह चुमिया ना बच्चे ਨੂੰ पता चलिया ना मानो ते कोई फायदा नहीं. Similarly, when we are treating our patients, we should be treating our patients 20 minutes नहीं थे, अभी 10 मिनट रहते हैं मेरे मुताबिक. तो वो तो बात ये है कि if we are treating a patient with respect and care, it should be seen to be that we are caring for them as well. It is not only good enough that we provide them the right treatment. We also have to make sure that they also understand that we are providing them the right treatment. So there are implications for our healthcare system, and the implications are not only for doctors. I would like, I'm glad Noreen is sitting over here, and maybe other administrators need to be sitting over here as well. The reason is we do not think this topic is important sometimes because only the doctors are affected. That is not so. It is not only the doctor that will be affected if there is violence. The whole system will be affected, and I will show you how the whole system is going to be affected. Now, these are the implications which are for the healthcare providers. We all know that they become unhappy, they're depressed, sometimes even suicidal because of the insult that they have faced. But the issue for the healthcare system is unhappy doctors will not perform well. Unhappy doctors will leave their jobs and try to go abroad maybe and seek other jobs. So unhappy doctors are not good for the healthcare system, and that is why the healthcare system needs to do something about it and think about their responsibility. How can they make hospitals safer places for doctors? So just a couple of things: the physical and psychological harm on the doctor, the emotional impact, the deterioration of the doctor-patient relationship is playing a significant role in this deteriorating situation, and we need to see what can we do to bridge this gap. The disruption of the healthcare services, आए दिन वाईडीए स्ट्राइक कर देता है, कई दफ़ा डॉक्टर्स की वायलेंस के अगेंस्ट, तो क्या है, तो हमारे क्या वो गलत करते हैं, क्या हमारी रिस्पॉन्सिबिलिटी नहीं है कि हम डॉक्टर्स को प्रोटेक्ट करें? वी नीड टू बी थिंकिंग अबाउट दैट, एंड वी ऑल्सो नीड टू बी थिंकिंग about the retention and the recruitment challenges that will come up for the administrators if good people start leaving their jobs. So it is important. WHO also says that we have to protect the doctors from violence in the workplace. In the next 5 minutes, I will try to show you what are the possible solutions and what can we do. So I have tried to group them into 4 categories. The first and the most important thing is that every healthcare provider should know of strategies to protect themselves. It is not only their own responsibility, but also of the institution where they are working. But this is very important. The Society of OBGYN needs to play a role for protecting their gynecologists, because OBG, as we all know, is a specialty which is actually a very high risk specialty. Anything can go wrong anytime. So if we do not have a protective mechanism, we are stuck. The institution should have their own policies, and Noreen, I am going to share with you the checklist that we developed at FIGO for protection against violence for doctors. Maybe you could implement it in this institute. And then the role of the commitment and the role of the government, that what can they do. So this is a serious issue, and the committee with which I was working with FIGO, the Committee on Women Facing Crisis of Human Rights, Refugees and Violence Against Women, has taken a serious note of that. And we have actually devised a questionnaire which is still, I think, can still be answered, and it is available on Facebook. And I will share the link as well, that you could make your voice be heard regarding the violence against the doctors. So there are a lot of steps that we outlined initially of mitigating the violence against the doctors. But these initial steps actually resulted in our creating a checklist for violence against doctors. Just sharing with you the outline of the possible solutions for violence against doctors. The first thing is that we have to educate ourselves and be aware. We have to have enhanced security measures. मैं सर्विसेज हॉस्पिटल में सारी जिंदगी काम करती रही. वहाँ जो गार्ड होता था, पहली बात उसके पास कोई आर्म नहीं होता था, और अगर वो आर्म्ड होता था तो वो फेक होती थी, और अगर वो फेक नहीं होती थी तो उसको चलानी नहीं आती थी, तो उसका कोई फायदा नहीं था. और सबसे पहले जब वायलेंस होती थी तो वही गार्ड जाके छुप जाता था. तो इसका मतलब ये होता था कि डिपार्टमेंट फुल ऑफ वुमेन and an occasional man like Dr. Tayyab would be there, but there's nobody to protect the doctors. So all the ladies are exposed, and in FJ the situation could be even worse. All the ladies are exposed to these hooligans who are going to do whatever they want to with you. So we have to have surveillance cameras, security teams, security measures. Workplace culture and supportive environment the environment should always be positive for a doctor, where we can work, we can be happy, and we can express what is happening to us, what is making us uncomfortable. And then training our doctors, क्योंकि डॉक्टर्स को ब्लेम किया जाता है ना, तो हमें डॉक्टर्स को ट्रेन करने की जरूरत है फॉर कॉन्फ्लिक्ट रेजोल्यूशन एंड फॉर मेकिंग श्योर दैट वी आर एबल टू de-escalate situations. मुझे अभी तक याद है, और मुझे घड़ी देखने वाले देख रहे होंगे, सर्विसेज हॉस्पिटल में आई वॉज इन AP, आई गॉट अ कॉल ऑन द डे ऑफ ईद कि एक पेशेंट थी, उसको एनेस्थीसिया दिया, द पेशेंट डाइड. And I think I was very young and stupid at that time. Probably I might not have had the same reaction today. मैंने पता नहीं क्यों कहा मैं आ रही हूँ। अब मेरे आने से क्या होना था, कुछ भी नहीं, बट आई थॉट इट वॉज माई रिस्पॉन्सिबिलिटी, सो आई वेंट देयर। और डॉक्टर ताहिरा फातिमा होती थी, मैं और वो और डॉक्टर लीना, हम 3 लोग थे और कुछ और लोग भी थे। तो वी वर इन द डॉक्टर्स ऑफिस, और बाहर मैंने देखा तो उसके रिश्तेदार खड़े हुए, उन्होंने बड़े बड़े बाले पहने हुए, गले में बीड्स थे, और वो अंदरून लाहौर के थे, और उनकी बहन ने उनकी मर्जी के खिलाफ शादी की थी, एंड दैट गर्ल हैड डाइड। और वो जो थे वो, अब जब हमने उनको बताया, और वी वर इन द सर्जन ऑफिस एंड वी कॉल्ड देम इन टू मेक देम सिट एंड टॉक, तो बैठे तो वो नहीं, लेकिन जो उनकी आंखों में चेंज आया उस वक्त, मेरे ख्याल में अगर मैं ये कह सकूं कि इतना फुलिश तरीका बताने का नहीं हो सकता था जितने से शायद हमने बताया। वी डिड नॉट टेक द राइट मेजर्स टू प्रोटेक्ट आवरसेल्व्स। और वो कह के उन्होंने कहा, अच्छा हमारी बहन मर गई है, आप ये कह रहे हैं? वो कह के बंदा पीछे गया है, तो ताहिरा एंड लीना वर स्मार्ट, उन्होंने कुंडी लगा दी और टेबल आगे कर दी। और उसके बाद ऑल हेल ब्रोक लूज इन द थिएटर, दे ब्रोक एवरीथिंग, एंड लेटर ऑन वी एंड दे केम फॉर अस फॉर लाइक मंथ्स, नॉट फॉर मी बट फॉर आवर जूनियर डॉक्टर्स, and in the end they killed the husband, they actually murdered the husband। और वो हमें किसी बंदे के थ्रू नहीं कहलवाना पड़ा कि यार हमें माफ कर, हमारा कसूर नहीं था पर हम फिर भी तुमसे माफी मांगते हैं, फिर हमारी जूनियर डॉक्टर्स बची। दिस इज द मैग्नीट्यूड ऑफ द सिचुएशन एंड वी नीड टू लुक एट इट। सो de-escalation techniques are important, and we also have to look at the workload of our doctors, because इतना workload होना चाहिए जो कि easily handle कर सके। Reporting and support system होना चाहिए। If I complain, as so when we complained and the police came, तो उन्होंने दरवाजा खुलने के बाद पहली बात क्या कही? बयान दो, बयान दो, बयान दो। हमने कहा we are traumatized, हम बयान नहीं दे सकते, but this is what happened। So reporting and supporting system होना चाहिए, law की जो है support होनी चाहिए, and hospitals should have legal measures to protect the doctors। You cannot fight these kind of incidents unless you have a strong legal system which is going to protect your doctors, so we need to work on that, and we need to be a part of the research and data collection so that we can make our voices heard कि ये हो रहा है। जब तक हम नहीं बोलेंगे, जब तक हम उसको लिखेंगे नहीं, जब तक पब्लिश नहीं करेंगे, it's not going to help us। So this is just I know many of you can't read, but I've just put in the 9 salient features of this checklist that we have developed, and I'll be happy to share it with everybody and anybody who wants to implement it in their own institutions। So basically, the Committee of Violence Against Women, and what it says is that all country societies should work with the healthcare providers, public and government, to mitigate the violence against the doctors. And the last thing, it's not the last, I've got 2 more slides, probably 3 to come up, but this is a link of the survey that if you want to be a part of this survey, you can just fill up the survey and it will go directly to FIBO, and we intend to publish a paper based on this survey, that what is happening around the world for violence against doctors. Just my last 2 or 3 lines that I want to say, which I think are very important. We are sitting in an institution where there are more female doctors and very few males. But we have got a good mix of male and female. I think that, and I may be biased if I say so, but I think I'm not, that the issue of violence against female doctors to me is a much bigger issue for various reasons. Their lack of ability to protect themselves. It is a country where it is easy to be violent against a female as compared to a male, because of the lack of that gender equality status that we want females to have. So I try to always link this violence also to the status of the women of this country. So if you look at the gender equality report of 2021 and we look at South Asia, so Pakistan ke jo figures of gender equality, and they are the worst in the region. Even for the South Asian region, we have the worst parameters. We are better than Afghanistan though, but I don't know how long we are going to be better than Afghanistan. So this is an important information that I wanted to share with you. So men are not equal to women, and gender equality is still a major issue, and this is the UN report. I'm not the one who's saying it. So if you look at this and the level of gender inequality prevailing not only in South Asia but all over the world, तो वेस्टर्न यूरोप को 52 years लगेंगे टू अचीव दैट इक्वालिटी, लैटिन अमेरिका को 68 years लगेंगे। लेट्स सी हमें कितने लगेंगे? हमें लगेंगे 195.4 years if we do something about it, which probably we are not. So इस चीज को भी देखने की जरूरत है, and this brings me to my last slide, and just like to share with you something, that not only we have to stop the violence against the doctors, we have to make sure that the environment which is existing for female physicians, that has to change, and we have to become a part of that change. We have to ensure that male and female gender actually becomes equal in our workforce everywhere that we do, and I will just stop with this. I don't know whether it will play here or not, but I would just like to stop with this. And thank you very much for listening so patiently to me. अभी प्ले नहीं हुआ है वैसे ये चला ये इसको प्ले करते हैं I'm not very familiar with this computer. Sorry for this. नहीं Okay, so इन्होंने उसका लिंक नहीं दिया. That's okay, but thank you very much.
Just add a few lines and appreciate your talk again, Dr. Sahel. I heard this talk during the International Congress in London, and Dr. Sahel had a standing ovation from all the audience, and we were literally in tears with this talk. So, congratulations, you've done so well. You highlighted such an important topic. In the UK, yes, there is violence. However, I've been working there for over 20 years, and the most violence I've faced is verbal abuse. And we have security cameras and all that, and we just call the security person, and that person is taken away. So no physical damage I've come across, but we need to work hard.
Thank you very much.
Thank you. Madam,
And we are so thrilled to have such eminent speakers on the occasion of the annual scientific symposium of FJMU and Chemca, UK. So I was a little late because my children were running fever. So I've joined in during Rubina's talk. And I would like to first acknowledge our chairs, Dr. Amreen Sajjad. She has come from UK, and she has, we will talk when she comes for a presentation, but she has been actively helping the Alumni Association in KEMU. They have conducted colposcopy courses, and she has so many diversified interests that when I first met Amreen, I thought, Amreen, आप इतना सब कुछ कैसे कर लेती हैं? So she is linked with medical education, with colposcopy, with laparoscopic surgeries, with subfertility, and various other subspecialties. And I would like to share with Amreen that we are trying to start the subspecialties of gynae in the Fatma Jinnah Institute of Maternal and Child Health. And our goal is to start in 2024. And we hope that you will help us with all your expertise and skill. So we welcome Dr. Amreen. And second chair is Professor Noreen Akmal, our most beloved principal, dynamic, versatile again, and trying to do so many things at the same time. I've always known Noreen. I don't know when in my memory I did not know Noreen. लेकिन यहाँ पे आके मैंने realize किया कि Noreen is a genuine gold person with a gold heart, or working to her full capacity to improve, और इनकी vision भी यही है कि to change the system of medical education for our undergrads. And Professor Shamsa Humayun, I'm very grateful to her. I am sitting in her unit, and she has been instrumental in bringing me to this institution. Professor Shamsa Humayun is also a living legend. वो कभी feel नहीं होने देती. She appears so cool and so calm. She is so very self-disciplined. अगर मैंने किसी से discipline सीखना हो तो मैं शम्सा से सीखूं. यहाँ पे ये वाइस चांसलर भी रही, प्रो वाइस चांसलर भी रही. शी हैज़ बीन वाइस प्रेसिडेंट ऑफ द सोसाइटी ऑफ ऑब्स्टेट्रिशियंस एंड गायनेकोलॉजिस्ट्स. शी इज़ नाउ actually practically not only faculty member of CPSP, but she's, as Gundal Sahib ne khud kaha, she is playing more role there as more than any people who are holding the chair of counselors. So Shamsa हमारी representative हैं CPSP में, medical education में, and in any matter we need help for in Fatma Jinnah Medical Institution and also university. She is very keen on research. ये भी मुझे इतना नहीं अच्छा अंदाज़ा था जब तक कि मैं इनके यूनिट में आई और मैंने देखा कि यहाँ पे कितनी इंटरनेशनल लेवल की
डिफरेंट रिसर्च पॉलिसी हो रही हैं। क्योंकि शमसा आपने पब्लिसाइज नहीं किया, हमें तो कहीं एडवर्ड में पता ही नहीं था कि यहाँ पे इतना काम हो रहा है। तो शमसा से आई एम अ बिलीवर कि मैं खामोशी से काम करती हूँ और मैं उसका जिक्र भी नहीं करती। प्रोफेसर और फिर हमारे कुछ अमरीन थे who people who were to deliver lectures who could not make it from UK at the last minute। तो मैंने परसों रिक्वेस्ट की और ये हमारी हैं बहुत सीनियर प्रोफेसर आलिया बशीर। शी इज़ ऑल्सो, इनकी जितनी तारीफ़ की जाए कम है। शी हैज़ कीन इंटरेस्ट इन मेडिकल एजुकेशन, लेप्रोस्कोपिक सर्जरी, promoting this change in system of education, in postgraduate education, and she's a very dear friend. So I requested her and she came and she has delivered a brilliant talk. We are very thankful, Alia. प्रोफेसर रुबीना सुहेल का तो नाम लेने की मुझे ज़रूरत ही नहीं है, बट शी इज़ वन पर्सन हु हैज़ ऑलवेज मोटिवेटेड मी। मैं कहती हूँ कि अगर कोई बन सके हम में से तो वो रुबीना सुहेल बने। अब शायद पॉसिबल नहीं है बट वी कैन ट्राई। तो मैं रुबीना सुहेल शायद बन नहीं सकी, लेकिन पहली दफ़ा किसी कॉन्फ्रेंस में मेरी वालदा हयात थी तो वो गई और शी वाज चीफ गेस्ट। तो उन्होंने कहा वो जो स्पीकर थी ना, आयशा वो तुम उसकी तरह लगती हो। मैंने कहा अम्मी मैं कहाँ से लगती हूँ, आपको शायद पता नहीं। मैंने कहा अम्मी को लगा है शायद। लेकिन उसके बाद मुझे काउंटलेस लोगों ने बाज़ार में रोक के, कॉन्फ्रेंसेस में, जो मुझे और रुबीना को दोनों को जानते थे लेकिन कराची से आए तो कन्फ्यूज़ हैं, तो कुछ मुझे कहते हैं कि मैं रुबीना सुहेली हूँ। मुझे पेशेंट से अपने किस्से सुनाने जहाज़ में, एयरपोर्ट पे, कि आपने मेरी फ़लाने वक्त डिलीवरी की थी और मुझे याद नहीं आ रहा। और फिर उसके बाद ये हुआ कि शादियों में, एंड देन दे फाइनली स्टार्टेड सेइंग कि आप रुबीना की बहन है। कल डॉक्टर तमिंदा की माइयों पे भी मुझे कहा गया कि आप डॉक्टर रुबीना की बहन है। फिर मैं कहती हूँ आप बहन ही समझें। तो रुबीना की एक पैशन है जो मेरी मदर में भी थी, विच आई कैन रिकग्नाइज, कि वो एट द कॉस्ट ऑफ देमसेल्व्स दे वांट टू अचीव समथिंग बिगर, एंड दैट बिगर इज़ नॉट वेल्थ, बिकॉज वो तो इनके पास पहले ही बहुत ज़्यादा होगी, एंड दैट वेल्थ इज़ नॉट इंक्रीज इन प्राइवेट प्रैक्टिस, क्योंकि वो इनकी पहले ही सबसे ज़्यादा है और मेरी अम्मी की भी थी। बट दीज पीपल आर मोटिवेटेड बाय समथिंग एल्स। इनको हम समझ नहीं सकते कि ये क्या है, इनको मोटिवेट क्या कर रहा है। इनको मोटिवेट करता है लोग, औरतों की जो पाकिस्तान में जो जेंडर इनइक्वालिटी है, जो विमेन हैं दे आर सफरिंग, उनकी जो पुअर मैटरनल आउटकम है, दे आर सफरिंग थ्रू रिपीटेड प्रेगनेंसीज, दे आर एडवोकेसी फॉर ऑल ऑफ अस, एडवोकेटिंग द हेल्थ, reproductive health, and not only in Pakistan but internationally. और so I would like to thank you very much, Rubina. It was a very interesting talk. हम किसे बयान करें तो हम सबके बहुत हैं। कि लेडी, मैं एक ही बस बताऊंगी कि लेडी विलिंगटन में मेरे यूनिट पे अब डॉक्टर्स के लिए इनजस्टिस रुबीना इसलिए कि वो सिस्टम इक्विप नहीं था। लोग आ रहे हैं, यू कैन नॉट रिफ्यूज़। और डॉक्टर अभी एक पेशेंट देखिए बाय लाइन लगी हुई है, तो एक का हस्बैंड आया और उसने कहा मेरी देखो, और थोड़ा सा हमारी कर्टसी लैकिंग है, सो द कम्युनिकेशन स्किल्स आर नॉट देयर, दे आर वर्किंग। तो उसने कहा मेरी बीवी को पेन्स आ रही हैं और तुम देख नहीं रही हो ये वो। तो शायद नर्स ने रूडली जवाब दिया, उसने ईंट उठा ली, और वो डॉक्टर जो थी वो भी 7 months प्रेगनेंट थी। वो टेबल के नीचे छुप गई बेचारी डर के। उसका मियाँ वाइडी का था, वो आया, गार्ड गायब था, एज यूजुअल मिसिंग। सो दीज आर कॉमन प्रॉब्लम्स, वी शुड एड्रेस देम, वी विल कोलैबोरेट, इंशाल्लाह वी विल collaborate at the level of Fatma Janab with Rubina, with our Vice Chancellor Sahib, and affect the government policy. Now our next speaker is my teacher and teacher of teachers, Professor Muhammad Tayyib. So big hand for him. और शायद मैं यहाँ ना होती अगर डॉक्टर तैयब ने हमें सेल्फलेसली ना पढ़ाया होता। सिर्फ मुझे नहीं, बहुत से लोगों को ही has been instrumental in guiding, ताकि हम FCPS और जो MRCOG है वो एट द सेम टाइम कर पाए, गिविंग सेल्फलेसली ऑफ हिज टाइम। हिज पैशन इज टीचिंग, आई बिलीव। और जब इनके नाम के आगे आप डिग्री से देखें तो आप नॉकआउट हो जाते हैं। प्रोफेसर मोहम्मद तैयब, प्रोफेसर ऑफ ऑब्स्टेट्रिक्स एंड गायनोकोलॉजी एट अल अलीम मेडिकल कॉलेज, बट MBBS, FCPS, MCPS, HPE, FCPS बांग्लादेश, FRCOG, MRCP पार्ट 1। डॉक्टर, ये आपको मेडिसिन का भी शौक था, आपने MRCP भी कर ली, FRCS, FACOG, MMFFP। सो ये मतलब ये भी जीनियस आइंस्टाइन किस्म के लोग होते हैं। जिन्हें भी पढ़ने का बहुत शौक होता है और उनका जो ब्रेन है वो भी नॉर्मल ब्रेन से शायद ज़रा डिफरेंट होता है, सो दे कैन डू ऑल दिस. बट डॉक्टर तैयब इज़ वेरी अप्रोचेबल, वेरी हम्बल, वेरी ह्यूमेन, एंड ऑलवेज हिज सेंस ऑफ ह्यूमर इज़ अनबिलीवेबल. तो इनके लेक्चर्स में हम इनके जो जोक है उसका वेट किया करते थे. मैं बहुत सारी तारीफें तो नहीं कर सकती, बट ही इज़ बेस्ट ग्रेजुएट ऑफ नेशनल मेडिकल यूनिवर्सिटी. He was the best teacher, university teacher of the year 2005. He was the past principal at Amiruddin Medical College. He's current professor at Al-Amin Medical College. He's the convener and examiner in Nepal, Bangladesh, and various institutions. I would take this opportunity to welcome Professor Khalid Masood Gondal, who is the moving force behind for this scientific conference. Sir, we are very thankful to you. आप 4-5 सेशंस को अटेंड करते हुए ही इज ऑनर्ड. ये हमेशा ऑब्स्टेट्रिक्स एंड गायनी एंड आर कॉज उसको सर फोकियत देते हैं हमेशा. डॉक्टर तैयब की इंट्रोडक्शन करते हुए ही इज़ ऑल्सो कंट्री हेड फॉर ऑल्सो वर्कशॉप्स in Pakistan and Saudi Arabia, and he has several to need countless national and international journal publications at his honor. And sir, we would like to request you कि आज आप फातिमा जी आए मेरे होते हुए, तो शायद पहली दफ़ा पढ़ाने के लिए आप हमें पढ़ाने के लिए आते रहा करें. बहुत शुक्रिया. And our registrar, Professor Nadeem Kasuri, is also my class fellow from King Edward, and our student chair, and Professor Khalid Masood Gondal. So I would request Professor Khalid Masood Gondal to please say a few words.
इनफैक्ट जब मुझे पता चला कि गायनी के बड़े लेजेंड्स आए हुए हैं तो फिर तमाम सेशन से होता मैंने कहा कि मैं डीएमए में आप सबका शुक्रिया अदा कर चलूँ. ऑडिटोरियम में फुल था सेशन, इसी तरीके से फिर लेक्चर थिएटर और फिर यहाँ डीएमए 4 सेशन दे आर साइमल्टेनियसली गोइंग ऑन वेरियस डिफरेंट टॉपिक. और रिप्रोडक्टिव हेल्थ इज़ वन ऑफ आई थिंक मोस्ट इम्पॉर्टेंट स्पेशलिटी. तैयब साहब जब भी बात करते हैं कि जी गायनी के फेलोज मैक्सिमम है, और मेरा पर्सनली ख्याल ये है कि जितनी सर्विस फातिमा जनाब मेडिकल यूनिवर्सिटी और गंगाराम का डिपार्टमेंट ऑफ गायनी कर रहे हैं फॉर हीलिंग ह्यूमैनिटी, फॉर द पेशेंट केयर, probably they are the number one as far as the number of the patient they are concerned. फिर अब MCH की establishment, and inshallah we have now decided in 2024 Professor Aisha, Professor Noreen, Professor Shamila, Professor Amna, सब मिल के we are going to start the 4 new subspecialty. Already notified हो चुकी है, and we are going to allocate 1 subspecialty to each unit starting from the gynecological oncology, then infertility, urogeny and reproductive medicine, जिसके बारे में आज भी बात हो रही है. So I am very grateful to Professor Tayyab. आप बाबा गायनी हैं या लग रहे हैं बाबा गायनी. प्रोफेसर बीना और जितने भी हमारे फॉरेन स्पीकर तशरीफ़ लाए हुए, मैडम आपका भी बहुत शुक्रिया. प्रोफेसर शमसा इस वक्त मौजूद हैं, डॉक्टर आलिया मौजूद है, आई थिंक एवरीबडी, एंड थैंक यू वेरी मच फॉर आर इन्वाइटिंग ऑल दीज वेरी सीनियर पीपल. तो अब आप कंटिन्यू करें और मैं फिर दोबारा हाजिर हूँ. तो ये सब ऐसे बड़े अच्छे हैं, आगे पिक्चर बनवा लेते हैं. एक बना लें फिर दूसरी. आई खड़े बाहर चेयर लगाई है, वहाँ पर फोटो बस है, चेयर लगाई बाहर. इतने सीनियर लोग आए हुए हैं, प्रोफेसर ब्रीड शायद नजर आ रही थी मुझे, और क्लास में लोग कैसे अब इनसे पूछे ताबिंदा से बड़ी है कि छोटी है, तो मेरे से बड़ी है, छोटी है. ताबिंदा इज माय क्लास फेलो.
Topic, and our very prestigious speaker जिनको सुनने के लिए हम कहाँ से जाते थे, वो खुद चल के यहाँ आए, प्रोफेसर मोहम्मद तैयब. Sir will introduce the topic himself, please sir.
Thank you very much, Aisha, Madam Chairpersons. What a great privilege to be here at Fatima Jinnah Medical University. And आयशा ने मेरी उम्र के बारे में आपको बताने की कोशिश की है कि मैंने इनको FCPS के लिए पढ़ाया. मैं उसमें फिर इजाफा कर दूं कि नौरीन अकमल आपकी जो प्रिंसिपल है उनको भी पढ़ाया था. और लेकिन ये वो दो स्टूडेंट्स थे जिनके बारे में मेरी उस वक्त राय ये थी, एंड प्लीज़ डू से कि मैं गलत कह रहा हूँ अगर मैं गलत कह रहा हूँ. नौरीन को भी और आयशा को भी मैंने कहा कि मैं इतना अच्छा वाइवा नहीं दे सकता, इतना अच्छा ऐसे नहीं लिख सकता जितनी जैसे ये लोग थे. तो ये वक्त ने साबित भी किया कि मेरे से कहीं ज़्यादा काबिल लोग हैं ये, माशाल्लाह. सो रियली प्राउड ऑफ यू एंड व्हाट अ प्रिविलेज. फातिमा जिन्ना मेडिकल कॉलेज था पहले, तो उसके साथ मेरी दूसरी एसोसिएशन ये थी कि मेरी जो वाहिद बायोलॉजिकल बहन है समिया भट्टी उसका नाम है, और वो अपनी मैडम शाहीना आसिफ जो हमारी गायनी की आइकॉन है, ये दोनों बहुत गहरी सहेलियाँ और बड़ी जज्बाती FJ की ग्रेजुएट्स थी. एंड माई सिस्टर एक यहाँ पे, आई डोंट नो आजकल वो डेजिग्नेशन है या नहीं है, ऑल राउंड बेस्ट स्टूडेंट एक होती थी डेजिग्नेशन. अच्छा, तो माई सिस्टर वॉज ऑल राउंड, नहीं एक बेस्ट ग्रेजुएट की होती थी, वो किसी और की थी, और एक होती थी बेस्ट ऑल राउंड स्टूडेंट ऑफ FJ. सो जो मल्टीपल चीज़ों में इन्वॉल्व. माई सिस्टर वॉज फॉर दैट ईयर शी वॉज द बेस्ट ऑल राउंड स्टूडेंट. एंड यहाँ पे कोई आपका एक फंक्शन होता था FJ का जो बॉन फायर कहलाता था. तो एक बॉन फायर होनी थी, तो मैं क्लास में 3 या 4 में था, बिकॉज माई सिस्टर इज़ 13 ईयर्स ओल्डर देन मी. 13 ईयर्स कम दोनों का फ़र्क. तो मेरा ख्याल क्लास 4 में था, प्राइमरी स्कूल में था. तो शी सेड कि बॉन फायर पे तुम्हें मैं FJ में लेके चलो. सो वो मुझे बॉन फायर पे यहाँ लेके आई व्हेन शी वाज इन फाइनल ईयर. और उस दिन बारिश हो गई, और बॉन फायर आपकी बारिश से शिफ्ट होके वारिस रोड हॉस्टल के किसी अंदर वाले कमरे में शिफ्ट हो गया. सो वो सारी मेमोरीज़ मुझे पता है कि मैं FJ में उस तरह भी आया था. उसके बाद गाहे बगाहे बहुत दफ़ा खैर में आता रहा. और आयशा आपने जो कहा अभी, मुझे ज़िंदगी में एक ही चीज़ का शौक़ है, वो पढ़ाने का है. तो आप मुझे 100 दफ़ा बुलाएंगी तो मैं 100 दफ़ा आऊँगा. नो प्रॉब्लम. Anyways, so yeah, this is the topic which is one of my favorite topics in my specialty, and I keep reading about it. And ये इस तरह की चीज़ है जो कि मैं और आप सब की तरह शायद एक प्रोफेशनल दिन में 2-3 पेशेंट्स तो ज़रूर देखता हूँ जो इससे रिलेटेड होते हैं. सो दैट्स हाउ कॉमन इट इज़. एक चीज़ जो मैं पब्लिकली लोगों को भी बताता हूँ और डॉक्टर्स को भी बताता हूँ, और ये चीज़ बड़ी इंपॉर्टेंट है, that the look of a polycystic ovary alone is a non-specific finding, and it can just be present in a woman who has got absolutely no other problem, no other abnormality. And polycystic ovary alone, you know, there is a world authority on PCO based in the United Kingdom called Adam Bailon. Adam Bailon इस पे books भी बड़ी लिखी हैं PCO. And Adam Bailon ने पहला data collect किया UK में different ethnicities के ऊपर. And from there, this data came that 33% of Asian women can actually have polycystic ovary. That means 1 out of every 3. So there is a lot of potential this overdiagnosed. And PCOS, which is actually the problem itself, is much lesser than that. So we need to understand that the look of a polycystic ovary does not necessarily mean a complete disaster. Because what happens in our country at least is that a young lady is told that she's got a polycystic ovary. She goes on Google. She then decides कि मेरी वफ़ात में थोड़ा सा वक्त बाकी है, और उस वफ़ात तक सिर्फ इनफर्टिलिटी, कैंसर और मेटाबॉलिक सिंड्रोम है, और उसके बाद कुछ भी नहीं है. एंड पीपल कम एंड से टू मी, कैन समटाइम प्रेजेंट लाइक दैट कि बस अब तो मरने का वक्त आ गया. This is just a few of the things that, few of the words that you'll pick up as we go along. So ये उसकी abbreviations हैं, और ये वो agencies हैं जिनके साथ related है जो data है या जो doc है. One of the things that I picked up in order to modify this talk, I've been doing this talk for a while, but to modify that, and that I think some of the very good updates I found was in this ACOG practice bulletin, American College, and I'll quote that in a minute. This I thought was most interesting. मुझे याद है कि 2003 में कोई 20 साल पहले जब पहली दफ़ा ये डिस्कशन शुरू हुई, तो उस वक्त there was a lot of paradigm shift and difference of opinion between North America and Europe. एक PCOS 1 कहते थे और एक PCOS 2 कहते थे, और उन आपस में कंसेंसस ही नहीं था. अमेरिकन कहते थे पॉलिसिस्टिक ओवरी का नज़र आना ज़रूरी नहीं है, यूरोपियंस कहते थे उसके बगैर आप डायग्नोज कैसे करेंगे. सो दिस द रॉटरडैम क्राइटेरिया, रॉटरडैम इज अ पोर्ट सिटी ऑफ द नेदरलैंड्स. वहाँ पे एशरे यानी एसआरएम वाले इकट्ठे हुए और उन्होंने फर्स्ट टाइम ये कहा कि जी 3 चीज़ों में से कोई सी 2 हो तो फिर आपको लेबल ऑफ PCOS किया जा सकता है. But then that was kind of endorsed by the Androgen Access Society and kind of this is still there. लेकिन इसके ऊपर बड़ी इंटरेस्टिंग मैं डिबेट पढ़ रहा था इस बुलेटिन में भी कि एक्चुअली पीपल have started challenging this as well कि अगर आपके सारे क्राइटेरिया को overarching include करेंगे तो you will probably be picking up out of 10 every 6 or 7 patients who will either be PCO or PCOS, and that's a little overdiagnosis and probably you don't need to go in that direction. This is very quick box just to remind us that we should never forget that there is a differential diagnosis. I personally have definitely picked up a few cases who were non-classical congenital adrenal hyperplasia or a Hylas tumor or something, and you just can't label everybody PCOS. Just be very careful with that. There is a differential diagnosis for people who have got PCOS. This particular slide is from a book called Evidence-Based Obs and Gynae for MRCOG by David Lewsley. I was David Lewsley's registrar in Birmingham, and it was a privilege when he brought this book out, 1995, the first time, and then obviously afterwards. And which states that it's like a continuum. It's not a definitive gray and white, black and white areas, because there can be a slim young lady who has just got a look of a polycystic ovary, nothing else wrong. And that can then continue to progress into something more sinister with the PCOS, but that influences on that can be a genetic predisposition and khas taur pe lifestyle and body mass index. Now, interesting thing is that the genetic contribution, it remains uncertain. We're very fond of asking patients कि तुम्हारी बहनों को PCOS है, तुम्हारी माँ को था, खाला को था, cousins में है, family में लोग मोटे हैं, diabetic कितने हैं. लेकिन ये uncertain है. I mean, it does not necessarily follow. Well, we see patterns, but it does not necessarily follow. And there is no genetic screening test, and there is no specific environmental substance identified. This is from the guideline. So मैं बड़ा enjoy करता हूँ जब मुझे क्लिनिक में patients inform करती हैं कि डॉक्टर साहब को पता है ना कि चिकन खाने से PCOS हो जाता है. And I अच्छा ठीक है, हम लोग तो अल्लाह का शुक्र है बहुत चिकन खाते हैं. We do know that there is an insulin resistance, especially in obese patients and lean patients, and we do know we can identify that, but that's never been identified as a diagnostic test to pick up PCOS. हमें पता है diabetes पाकिस्तानियों में, Asians में, Caucasians की निस्बत 4-5 गुना है. We all know that. All types of diabetes, type 1, type 2, and GDM, we know that. And that also is based on insulin resistance. So what does insulin resistance do? And I'll not delve into details of that because take up all of my time. But we do know that through various pathways, it is going to change the androgenic milieu of the ovary from where this kind of pathophysiology perpetrates. We also know that about 1 out of 3 patients have got impaired tolerance, and about 1 in 10 will have type 2 diabetes at some stage. Insulin की बात हमने की, and what insulin androgens what are going to do? They're going to lower the sex hormone binding globulin, and therefore they're going to increase a little bit of testosterone which is circulating. लेकिन प्रॉब्लम ये है कि जो वेट का एसोसिएशन है, a lot of patients just come and say कि डॉक्टर साहब देखें ना मुझे जो कि PCO था तो मैं मोटी हो गई. They do not realize that because they put on weight, that is what potentiated PCOS. So this is the sequence is wrong. अगर हमारी बहनों बेटियों को यही बताया जाता है. Now, in terms of the hormonal milieu, we are aware that androgens, the adrenals, they secrete weak androgens, which is dehydroepiandrosterone sulfate and and epiandrogen. But this is about 90% of the source of these weak androgens come from adrenals. These and androstenedione, अगर आपको वो precursor pathway याद हो, they are the hormones for testosterone and dihydrotestosterone, which is converted in liver fat and skin. Ovary से आता है mostly जो testosterone आता है. That's the basis. But we also know that there's a mild prolactin elevation in PCOS, and mild prolactin elevation is not that significant in terms of management. हमें ये पता है कि thyroid disorder is 9 times commoner in women, and 9 times out of 10 it is subclinical. So it's useful to have a TSH as a baseline to check that. Insulin levels मैं रोज़ 1-2 patients के नुस्खे देखता हूँ कि डॉक्टर्स ने करवाए होते हैं. Guideline में there is no evidence कि करवाने का कोई फ़ायदा है. How do you pick it up? Well, obviously history is obviously most important. खास तौर पे कुछ लोगों की बड़ी dramatic history होती है, and they're put on weight and their periods are erratic and irregular, and so on. Obesity is not a diagnostic criterion for that, and 1 in 5 at least PCOS patients are not obese, and we know that. Menstrual cycle disturbance, infertility or subfertility, and the presence of hyperandrogenism features. This is from the guidelines, so we don't need to go through the whole box, but it's just what is the suggested evaluation for patients with PCOS. Blood pressure, BMI, waist circumference, and any stigmata of hyperandrogenism. Lab में total testosterone SHBG, exclusion of any other causes of hyperandrogenism, evaluation of metabolic abnormalities by GTT. Pakistan में तो थोड़ी सी obese patient तो हम कर लेते हैं, and then fasting lipid and lipoprotein level. This, I don't know how many of us clinically follow that, but the Ferryman-Galway score is an objective assessment of us. ये इसलिए थोड़ा सा अहम है उस point of view से that हमारा जो health seeking behavior है उसमें कुछ patients with very mild hirsutism are worried, and some patients with significant hirsutism will not be contacted. So as an objective assessment, if we have some chart to look at, then it's easier for us to have an initial evaluation and to follow that, and we're aware of that. So once we've done that, examination done, what is anything else that we need to do? Well, ultrasound examination, determination of polycystic ovaries in one or both ovaries. ये दोनों में होना ज़रूरी नहीं है. One is fine. 12 or more follicles measuring 2 to 9 millimeters in diameter. Any endometrial aberrations. Optional tests बड़े कम किए जाते हैं. gonadotrophin determinations अगर एमेनोरिया आपने पकड़ना हो, fasting insulin in younger women जिसमें insulin resistant के severe stigmata, although it's not a frontline thing that we do. And अगर आपने वो पकड़ना है, Cushing is very rare, by the way, extremely rare. This was one of the classic, जो शुरू में necklace appearance बताते थे वो, और वो बात भी ख़त्म हो गई है कि even if you have follicles which are scattered in the stroma, that is also fine. और फिर ये दो तीन ऐसे थे. This was from David Lewsley's book, and I thought this was interesting, although we don't necessarily label people like that. Saha syndrome and Hayran syndrome and dysmetabolic X syndrome. These are all variations on the theme of severe PCOS. And अगर patients इस किस्म के spectrum में fall कर रहे हो तो we can label them. Although clinical setting में we hardly label and pick up patients like that. This is particular acanthosis nigricans. You have a thick band or a thick velvety kind of skin patch in the neck, axilla, sometimes groin, popliteal fossa can be there. This guideline, which is long-term consequences of polycystic ovary, this was Green Top 9, which was revised in 2014. I looked it up last night. It has not been revised since. It's not been archived either. लेकिन इसमें 3-4 चीज़ें थी जो इंटरेस्टिंग थी. ये पहली दफ़ा जब आई थी 2003 में, फिर 7 में, फिर 14 में. Obese patient में sleep apnea is a problem as a long-term consequence. Metabolic disturbance definitely is worrying if they keep putting on weight. Mood disturbances and depression. इसके ऊपर data last 10 years में ज़्यादा आया. It's very interesting. On one hand, you have an endocrine challenge, and then on top of that, if you also have mood disturbance and depression, that compounds the issue. And then possibility of endometrial cancer if it persists more than a decade or so. And then definitely more risk of GDM and hypertension in pregnancy. And this I thought was very interesting because जब मैंने इसका data पढ़ा तो उन्होंने कहा यार एक तो पहले से PCOS को हो, उसको conception में difficulty हो, और उसके बाद अगर वो conceive कर जाए and you have a pregnancy, then be on the guard because this girl can get GDM and hypertension both because she had PCO. And management के principles में, because हमने कहा कि the only variable that can make a PCO turn into PCOS is lifestyle changes and lifestyle like that in which you are living a certain. So lifestyle changes always is paramount in number one. Weight reduction in obese individuals and only 10% loss of visceral fat decreases testosterone because it increases sex hormone binding globulin. So that is the principle how weight loss works. और मैंने आज से को 15-20 साल पहले पढ़ा था द फर्स्ट टाइम कि अगर 10% वेट लॉस भी किसी में आप हाई BMI में करने में काबिल हो जाएं, it doubles the ovulation rate, it doubles the conception rate, it triples the successful pregnancy rate. मैंने सोचा यार just imagine कि इतनी छोटी सी बात कि आप मुझसे कहें कि बस 10 kg वेट ड्रॉप कर लो तो ये तीनों चीज़ें हो जाएंगी. It obviates the need, it just reduces the need for any kind of major interventions then. So sometimes I say to patients, एक काम करें 3 महीने के लिए घर जाएं, 10 kg ड्रॉप करके वापस आ जाएं, and half of them come back and say I have a pregnancy. Alhamdulillah. So we know that. And android obesity we know is risky. And regular exercise and weight loss is proven for cardiovascular disease reduction. Proven. So something that is proven scientifically. I'm sure you're all aware of that, how BMI is calculated. There's nothing new to say here, except that we know that anybody who's got a BMI of 30 plus. वैसे by the way, पिछले 2-3 सालों में BMI भी challenge होना शुरू हो गया कि BMI alone जो है वो बड़ी simplistic बात है किसी को कहना, क्योंकि हर बंदे का individual एक figure भी होता है, and sometimes BMI इतना ज़्यादा important नहीं है जितने other risk factors important हैं. वेट रिडक्शन के लिए आई वाज लुकिंग अप, दिस आई थॉट वाज वेरी इंटरेस्टिंग मेडिकेशन जो पाकिस्तान में आना शुरू हुई है, ग्लूकागॉन लाइक पेप्टाइड GLP. दुनिया में हुआ ये कि जो आपकी फार्मास्यूटिकल इंडस्ट्री है, दे हैव गॉन ऑन अ बैंड वैगन, एंड बिकॉज ओबेसिटी इज़ अ पैंडेमिक इन द वर्ल्ड. ये पहली 2 मेडिसिन पाकिस्तान में अवेलेबल हैं, लिराग्लुटाइड, सेक्सेंडा को वो प्रमोट करते हैं लोगों नॉर्डिस्ट. मैंने इस स्टॉक के लिए एक्चुअली फ़ोन किया उन्हें हफ्ता पहले कि मेरी बात सुने, ओजेम्पिक के लिए मेरे पास नहीं आते, वो पहले सेक्सेंडा उठा के रोज़ ले आते हैं. तो उन्होंने कहा जी जो ओजेम्पिक है ना वो FDA ने शायद कहा नहीं हुआ कि वो करने के लिए, तो हम अब इसको उस तरह से प्रमोट नहीं कर रहे. बट उसके ऊपर ट्रायल बहुत ज़बरदस्त हुआ था एंड वाज वेरी इंटरेस्टिंग. एंड दूसरी 2 मेरा ख्याल है अभी एलाई लिली वाली पाकिस्तान में नहीं आई है. एंड देन द सेकंड ड्रग इज़ ओलिस्टैट. एक तीसरी थी जो ख़त्म हो गई पाकिस्तान से, अब चली गई. बट ओलिस्टैट के कुछ प्रेपरेशंस हैं जो मैंने इसमें देखी हुई है. कुछ पेशेंट्स कई दफ़ा आके कहती हैं कि डॉक्टर साहब मुझे वो ऑर्सलिम दे दें, एबनिल दे दें, और ऑलिस दे दें, सो ऑन. Bariatric surgery, I think now Lahore में there are 4 or 5 surgeons who do it now. They're very good with it and काफ़ी expert up हो गए हैं. But we know that treatment for morbid obesity, more than 40 or BMI 35 with comorbid, and इसमें सिर्फ एक take home message है bariatric surgery में, that anybody in whom you do that, 1 साल तक उसको pregnant नहीं होना चाहिए, because उसने 130 kg से 60-70 पे आना है 1 साल के अंदर. The so dramatic drop in weight के दौरान उसको pregnant नहीं होना चाहिए. So you have to give contraception to somebody जिसको bariatric surgery आप advise करते हैं. Clinical updates in women's health care. एक चीज़ जो जिसको मैं कभी लिफ्ट नहीं कराता था, and I just shared this with you, कि जब कोविड पीक आया तो लोगों ने कोविड की पीक के 2 सालों को मुख्तलिफ तरीक़ों से इस्तेमाल किया. मैंने उसको बहुत सारी गायनी ऑप्स पढ़ने के लिए इस्तेमाल किया. मैंने काफ़ी मेजर बड़ी टेक्स्ट बुक्स खरीद के फर्स्ट टाइम लाइक स्टूडेंट कवर टू कवर पढ़ी, जिसमें बेरेक एंड नोवैक मेरी एक फेवरेट बुक है. वो कोविड के शुरू में नई आई थी, नया एडिशन. 1800 पेजेस आई रेड फ्रॉम पेज 1 to 1800 एंड मेड नोट्स ऑन 500 पेजेस. मतलब शाजिया नोज अबाउट दैट स्टोरी, सॉरी. एंड उसमें 2 चैप्टर्स थे जिन्होंने मेरी आंखें खोल दी. एक चैप्टर था कॉम्प्लीमेंट्री एंड इंटीग्रेटिव हेल्थ केयर, CIH. और मैंने फर्स्ट टाइम पढ़ा कि यूनाइटेड स्टेट्स में एक अमेरिकन बोर्ड बन गया है, बोर्ड ऑफ CIH, कि मेडिकल डॉक्टर्स को वो कहते हैं कि वो ट्रेन करते हैं 4 साल के लिए कॉम्प्लीमेंट्री एंड इंटीग्रेटिव हेल्थ केयर में. और मेरे लिए बड़ा इंटरेस्टिंग था कि मेरे पास कोई हकीम होम्योपैथ की बात करता तो मैं कहता बाहर निकल जाओ. एंड आई रियलाइज्ड कि नो, दिस इज़ अ रियलिटी इन द वर्ल्ड एंड यू हैव टू लिव विद इट, यू हैव टू अंडरस्टैंड इट. ये एक चीज़. दूसरा चैप्टर था मेडिकल एंड सर्जिकल इश्यूज़ इन ऑब्स एंड गायनी, और उसमें उसने सिर्फ पैगाम ये दिया था कि आप जब हर पेशेंट को भेज देते हैं ना कि हाइपरटेंशन के लिए वहाँ चले जाओ, डायबिटीज़ के लिए वहाँ चले जाओ, अगर डिप्रेशन हो रही तो वहाँ चले जाओ, और ख़ुद दवाई लिखने को तैयार नहीं होते, पेशेंट का ट्रस्ट आप पे उतना नहीं होता. आप पेशेंट के डॉक्टर हैं तो आपको ये बेसिक थोड़ी मेडिकेशन लिखनी आनी चाहिए, हर चीज़ के लिए मत भेजा करें. ये दोनों बड़े दिलचस्प चैप्टर थे मेरे लिए. सो दिस वाज वन ऑफ देम, एंड देयरफॉर आई थॉट कि अच्छा यार ये जो रंग बिरंगे मेडिकल रेप्स आते हैं ज़रा सुन लो क्या कह रहे हैं. And this is what came from that paper. This is a ACOG guideline on the website, and it said okay, several dietary supplements polycystic ovary में दिए गए हैं जिसके अंदर they are based on inositol, myo-inositol, and D-chiro-inositol. They can reduce insulin resistance and androgen levels in PCOS. It was interesting. And I went to the ACOG conference last year, and वहाँ पे was a plenary के अंदर एक 1 hour का था जिसके अंदर उन्होंने first time कहा कि मतलब whether you like it or not, but this is now coming in a kind of additional way. So this is not a mainline pharmaceutical drug; it is supplementary, but okay, it may have a role in our country. And the dosage that ACOG advises for inositol for PCOS is 2 grams twice a day. But that's obviously because इसके ऊपर कोई major studies नहीं है, तो ये एक suggestion है. सो मैंने सोचा कि मैं पाकिस्तान की फार्मेसी देखूं ज़रा क्या क्या यहाँ पे है. मेरा ख्याल है कोई 50-60 हैं तकरीबन. तो ये मुझे चंद एक इनिशली जो फ़ौरन नज़र आई, क्योंकि ये हर रोज़ दरवाजे के बाहर खड़े होते हैं, तो मैंने कहा मुझे देना ज़रा क्या है. एंड टिनोस्टॉल, जेनिस्टॉल, ओवाप्रो और ये फोलिक टाइम, ये मेरा ख्याल इसके अलावा भी हैं.
The most common of these is the cervical cancer.
Who's this?
And what we know is that 91% of
ये क्या हुआ?
cervical cancer.
अच्छा सर, couple of comments on hirsutism and PCOS. Problem with hirsutism is there is no clear known primary treatment for that. Most approaches are palliative. hirsutism पे मैं पूरा घंटा बात कर सकता हूँ, but I'll control myself. There is no one OCP which is superior to another, except perhaps Yaz because it has drospirenone, वो पाकिस्तान से withdraw गई है. Other choices जैसे spironolactone, flutamide, finasteride मखले यहाँ available ही नहीं है. जो मुझे सबसे ज़्यादा एविडेंस मिला वो ये इस दवाई का था, एफ्लोरनिथीन अप्रूव्ड बाय FDA. It's a cream which you can use and I don't think it's available here. And then adjuvant cosmetic laser is helpful and all these things. Menstrual irregularity, अगर obese है तो weight reduction will help in PCO. Any COCP that you give with lower LH and lower ovarian androgen and increase SHBG, so it helps with that. FDA ने मेटफॉर्मिन को प्रूव नहीं किया हुआ, लेकिन यहाँ पे कुछ एंडोक्राइनोलॉजिस्ट लाहौर में काफ़ी देते हैं फॉर वेट रिडक्शन, ऑल्दो इट्स नॉट प्राइमरीली अ वेट रिड्यूसिंग ड्रग. देन मुझे किसी ने कहा डायन तो मिलनी बंद हो गई है, कहीं से मिलती नहीं है, तो आई लुक्ड अप द फार्मा गाइड पाकिस्तान जो बुक छपती है हमारी लोकल, तो उसमें मुझे 5-6 नाम मिले कि उसी प्रेपरेशन के 5-6 नाम और भी पाकिस्तान में मिलते हैं. इसको आप प्रैक्टिस, क्योंकि हम प्रैक्टिस में यूज़ कर रहे होते हैं तो हमें फ़ौरन पता होना चाहिए कि डायन नहीं मिल रही तो क्या देना है. तो चंद एक ये थे. And finally, anovulation and infertility, somebody is trying to conceive with that. Obviously, PCOS में weight loss helpful है. Smoke cessation, alcohol, although looks fancy, लेकिन हमारे मुल्क में there are some categories of people who are into that. Letrozole, octomorphine दोनों. Anastrozole सिर्फ एक कंपनी बना रही है. Gonadotropins मेरा ख्याल है unless कि you have got good backup center, you should not be doing it alone. And ovarian drilling का role second line है. क्लोमिफेन लेट्रोजोल की कहानी कई सालों से मैं सुन रहा हूँ और मैं कई कॉन्फ्रेंसेस पे जाके मैं लेट्रोजोल पे मूव नहीं हुआ बड़ी देर, हालांकि आई उसको 15-20 साल हो गए, लेकिन ये जो पेपर्स थे दे वर काइंड ऑफ ग्राउंड ब्रेकिंग इन दैट सेंस व्हिच प्रूव दैट लेट्रोजोल वाज सुपीरियर टू दैट lesser OHSS and all that, and these are recent papers that over the few years. तो then I looked up कि अच्छा जी इसमें हमारे मुल्क में अगेन मेरा ख्याल है काफ़ी सारी प्रेपरेशंस हैं, मैंने चंद एक लिखी हैं इसमें, यू familiar with that कि हमारे मुल्क में क्या क्या मिल रहे हैं दोनों में. I personally now last couple of I think 2 to 3 years I've used letrozole more than clomiphene, to be honest. Finally, role of ovarian drilling. Ovarian drilling is kind of come and gone. जो लोग लेप्रोस्कोप लेकर आए थे वो इतने एक्साइटेड थे अपनी लेप्रोस्कोप के लिए कि वो होता था. और मैं हमारी एक सीनियर कॉलीग हैं डॉक्टर सादिया खान फैसलाबाद में, आप सब जानते हैं, बहुत काबिल डॉक्टर हैं. मुझे उनका एक दिन फ़ोन आया बड़े गुस्से का कि तैयब ये कौन है लाहौर में जो कि सारों की ओवरीज को भून रहा है. मैंने कहा भून रहा है? उन्होंने कहा हाँ भून ही जा रहा है. मैंने कहा अच्छा क्या हो गया? तो उसने कहा 24 साल की एक बच्ची है फैसलाबाद की, बहुत अमीर इंडस्ट्रियलिस्ट की वो बेटी है, उसकी ओवरीज भून दी हैं, उसका जो है ना FSH 50 है और AMH 0.1 है. तो अब उसका मैं क्या करूँ? उसको बेड़ा गर्क कर दिया जस्ट बिकॉज शी हैड PCOS. वो गई है लाहौर, उन्होंने फटाफट उसकी ओवरीज में नीडल्स डाल के दोनों ओवरीज रोस्ट कर दी हैं. शी इज फिनिश, शी इज मेनोपॉजल नाउ. हु इज डूइंग दिस? मैंने कहा जी अच्छा चलो पता करते हैं. But anyways, so you know, so it's not like a willy-nilly or I know a very senior laparoscopic surgeon 20 years ago saying on a forum that ovaries should be treated with by ovarian drilling. You change them into a golf ball, put so many needles in it, it will destroy the ovary. So you have to be very careful. So it basically principle तो ये है कि वो thermal damage से थोड़ा सा बेहतर होगा. It will decrease androgens by 50%. It has no value in hirsutism or obesity. So it reserved for very select women. So you have to be very, very careful if you choose that. और obviously आप उनमें choose करते हैं जिसमें आप gonadotropins को लगा के monitor नहीं कर सकते. But be very careful. I think yeah, one last comment on metformin therapy. और ये 2017 में पेपर आया था रॉयल कॉलेज से, और उसमें था कि it is basically for prevention of diabetes mellitus if you want to give it long term in PCOS. And we know how it works. It may be associated with weight loss if it's, अब तो हम प्रेगनेंसी में देते हैं, हम मेडिकल स्टूडेंट थे तो पढ़ते थे कि मेटफॉर्मिन ना दें, अब तो मेटफॉर्मिन प्रेगनेंसी में बहुत रेगुलरली यूज़ करते हैं. एंड इट्स नॉट अ फर्स्ट लाइन ट्रीटमेंट ऑफ चॉइस अकॉर्डिंग टू दैट RCOG पेपर, बट हम लोग काफ़ी सारे मेटफॉर्मिन यूज़ करते हैं. So take home messages. PCOS is a disorder characterized by hyperandrogenism, ovulatory dysfunction and PCOS, possible ovaries. There is a heterogeneity of symptoms and signs. They're not uniform. They may keep changing through life. And polycystic ovary does not always mean PCOS. The patient will come to you crying. Insulin resistance is the key factor in most cases. And it has the potential to cause substantial metabolic sequelae like diabetes, cardiovascular disease. Etiology is 2018 guideline updated, remains unknown. Treatment is largely symptom based and empirical. जब आप ये कह देते हैं ना किसी guideline की bottom line में कि the treatment is largely symptom based and empirical, then you give this leeway to consultants to treat it differently. It's all right. It's not in black and white, so we don't know. And it's okay to use a supplement. It's okay to use this, that. High LH-FSH ratios जो हम medical student थे तो रटा लगाया करते थे कि ये 3:1 होना चाहिए. It's absolutely obsolete. Similarly, peripheral follicles on scan are not diagnostic. Symptoms and hormones are never consistent. You can have a severely symptomatic patient with a normal hormone, तो आप उसको ये नहीं कह सकते कि जाओ तुम्हें कुछ नहीं है. अगर वो erratic हैं तो हैं फिर. Classically, it's lifelong. It's like diabetes. It stays with you lifelong. But features in an individual may change over time. And in obese patients, weight loss is the cornerstone of therapy. Thank you very much.
Thank you, Dr. Tayyib. As usual, it was enthralling. हम बिल्कुल we were holding our breaths and listening because इतनी updates होती हैं और डॉक्टर तैयब हमेशा अपनी source भी quote करते हैं, year भी quote करते हैं, and I'm so impressed कि totally evidence based topic था, very useful. I would like to thank Professor Rubina, Professor Alia Bashir because of the work constraints they have just left. And हमारी next talk and second last is because Dr. Amreen has kindly consented that hers will be the last topic of this session and the most important. तो अभी एक है road map of cervical cancer screening, and I know कि मेरे सामने बहुत से eminent oncologists बैठे हुए हैं, Professor Amna जिन्होंने 20 साल लेडी विलिंगटन में colposcopies की and has never broadcasted it in that respect, just providing a service to the poor patients. और माहम है जिनका special interest है in oncology and हमारे बहुत से aspiring young persons. So this is recently Fatma Jinnah has won with Professor Dr. Noreen Zafar who जो गोंदल साहिब की class fellow हैं, and here I'm right in quoting कि वो गोंदल साहिब की class fellow हैं, and she is working in the private sector, and we have been awarded WHO मुझे नहीं पता कितने $1 million की स्टडी फॉर फाइंडिंग आउट कि यहाँ पे प्रेवलेंस कितनी है, एंड दिस इज़ पार्ट ऑफ अ मल्टी सेंटर इंटरनेशनल ट्रायल जिसमें वो मिड मेडिटेरेनियन रीजन और साउथ अफ्रीकन रीजन में विमेन में ये ब्रेस्ट और सर्वाइकल कैंसर का पहले प्रेवलेंस पता करने लगे बिकॉज हमारी तो कैंसर रजिस्ट्री नहीं और प्रॉपर डॉक्यूमेंटेशन नहीं. सो ऑन बिहाफ ऑफ डॉक्टर नौरीन जफर, प्रोफेसर फौजिया अंबर, अब मैं अपनी एज नहीं छुपाती, शी इज़ माई फर्स्ट स्टूडेंट जिसने सबसे पहले FCPS किया. When she was a trainee, we used to be impressed by her presentations. She is head of the Department of Obstetrics and Gynae at Shalamar Medical College, and she has special interest in laparoscopic surgery, in infertility, urogynae, बहुत complex procedures करती हैं, again without advocating इनकी expertise कितनी है. तो Dr. Fawzia, please come and share the talk.
जी, अस्सलाम वालेकुम. Thank you so much for this lovely introduction. और डॉक्टर आयशा मलिक खुद जितनी प्यारी हैं उनके अल्फाज भी उतने ही प्यारे हैं. और ऐसा है कि मुझे आज आई एम सो हैप्पी टू बी हेयर इन फातिमा जिन्ना, यस, इन फातिमा जिन्ना मेडिकल कॉलेज, बिकॉज 30 साल पहले मैंने इधर ही पढ़ा है, इधर से ही ग्रेजुएशन की है, और यही इतने मानूस कमरे हैं और सारे. और फर्स्ट ऑफ ऑल मैडम चेयर्स, सिटिंग ऑन द चेयर्स, मैडम शमसा, थैंक यू सो मच. वाकई मैडम से हमने डिसिप्लिन सबसे ज़्यादा मैडम शमसा मायने से सीखा. और मैडम नौरीन अकमल, आई एम सो मच, आई कॉन्ग्रेचुलेट यू टू बिकम अ प्रिंसिपल फातिमा जिन्ना मेडिकल यूनिवर्सिटी. हम जब अभी इधर मेडिकल स्टूडेंट थे तो मैडम बेसिक साइंसेस में डेमोन्स्ट्रेटर थी, फिर मैडम हमारे सामने गायनाकोलॉजी डिपार्टमेंट में फॉर पोस्ट ग्रेजुएट स्टडीज़ शिफ्ट हो गई. मैडम से हम तब से देखते हैं, इनको जानते हैं, इंस्पायर हैं. और थैंक यू मैडम. डॉक्टर अमरीन के साथ भी यहाँ आकर मेरा लिंक एस्टेब्लिश हो गया. और डॉक्टर तैयब मेरे भी टीचर हैं सबके टीचर हैं, मेरे भी टीचर हैं. डॉक्टर तैयब से हमने FCPS पार्ट 2 के कोर्सेज में इतना ज़्यादा पढ़ा, और डॉक्टर तैयब FCPS पार्ट 2 में ऑब्स्टेट्रिक्स के लॉन्ग केस में मेरे एग्जामिनर भी थे. सर को शायद याद नहीं है, और सर ने मुझे पास किया था FCPS पार्ट 2 में. बाकी मेरे ये सारे जितने मेरे सामने बैठे हुए हैं सारे मेरे बहुत अच्छे कोलीग हैं. कहीं ना कहीं टाइम टू टाइम इन सब लोगों के साथ इंटरेक्शन होता रहता है. मैडम शमीला के साथ, डॉक्टर आमना के साथ, और विलिंगडन में हम इतने सब, मैंने 15 साल लेडी विलिंगडन में भी सर्विस की है. और बाकी पब्लिक सर्विस कमीशन में भी हम सब लोगों के इंटरेक्शंस अपने सारे कोलीग्स के साथ होते रहते हैं. and I'm so happy to be here. Thank you so much for giving me this opportunity to have this talk. और डॉक्टर नौरीन ज़फ़र ने मुझे डेडिकेट किया, उन्होंने मुझे डेलीगेट किया कि मैं ये टॉक यहाँ पे दूँ. These are some of my credentials. अच्छा, सर्वाइकल कैंसर एलिमिनेशन स्ट्रेटजी, ये है हमारी आज की टॉक, और जिसके बारे में मैडम आयशा मलिक ने अभी बताया कि फातिमा जिन्ना मेडिकल यूनिवर्सिटी हैज़ वन अ ग्रांट टू फाइंड आउट द प्रेवलेंस ऑफ सर्वाइकल कैंसर. मैं आई वॉज रिकॉलिंग वाइल आई वॉज सिटिंग हेयर कि जब मैं मेडिकल स्टूडेंट थी तो हमारे जो क्वेश्चंस दिमाग में आते थे एज एन अंडर ग्रेजुएट स्टडी, हमारी बुक्स में सिर्फ सर्वाइकल कैंसर, उसके रिस्क फैक्टर, उसके सोशल सेक्सुअल टैबू, सोशल स्टिग्मा और ये सारी चीज़ें, और सेक्स वर्कर्स के साथ उसकी एसोसिएशन और ये वाली सारे प्री डिस्पोजिंग रिस्क फैक्टर्स, हम अर्ली ऑनसेट सेक्सुअल एक्टिविटी, और इस तरह से हम इसको पढ़ते थे. हार्डली हमारे कॉन्सेप्ट्स कभी सर्वाइकल कैंसर स्क्रीनिंग या उसके सर्वाइकल साइटोलॉजी और उसके नेशन वाइड प्रोग्राम्स के बारे में हमें एज अंडर ग्रेजुएट तब इतनी अवेयरनेस नहीं थी. उसके बाद वाइल ड्यूरिंग द पोस्ट ग्रेजुएट स्टडीज़ फॉर द फर्स्ट टाइम जब हमने बहुत ज़्यादा इंटरनेशनल बुक्स पढ़नी शुरू की, देन वी फाइंड आउट के पैप स्मीयर है, उसके 3 ईयरली स्मीयर्स हैं, ईयरली स्मीयर्स हैं, और पूरा नेशन वाइड स्क्रीनिंग प्रोग्राम है. देन वी रियलाइज्ड कि हम कितने पीछे हैं बीइंग एन अंडर डेवलप्ड नेशन, and how things are being laid down for public health and for preventive health and for treating and diagnosing and screening the diseases while they are still at a preventable stage. तो हम वाकई अभी जैसे वायलेंस में भी डॉक्टर बताया, डॉक्टर प्रोफेसर रुबीना सुहेल ने, कि हमें हो सकता है 100-200 साल लग जाए जेंडर इक्वालिटी तक जाने में ही. इसी तरह हो सकता है कि हमें प्रिवेंटिव स्ट्रैटेजीज़ और अपनी पब्लिक हेल्थ में प्रिवेंशन को प्रमोट करने के लिए और स्क्रीनिंग प्रोग्राम को नेशन वाइड स्प्रेड आउट करने में भी हो सकता है कि वी माइट टेक 100 years और सो. अभी तो इस वक्त पाकिस्तान में कोई ऐसा नेशन वाइड प्रिवेंटिव स्क्रीनिंग प्रोग्राम फॉर सर्वाइकल कैंसर स्क्रीनिंग इट इज़ नॉट प्रेजेंट. इट इज़ ओनली द डिस्क्रेशन ऑफ द गायनाकोलॉजिस्ट्स who either undergraduate medical students, gynecologists, GP gynecologist, as well as postgraduate students और जो specialist and consultant जो opportunistic screening कर रहे हैं pap smear की. So और cervical cancer के लिए. और उसके बाद I have attended a number of workshops. लेडी विलिंगडन में डॉक्टर आमना ने भी हमें की, और उसके बाद मैंने कॉल्पोस्कोपी की वर्कशॉप इस इंस्टीट्यूट में भी अटेंड की फॉर HPV DNA स्क्रीनिंग टेस्ट्स एंड सो जो भी स्क्रीनिंग टेस्ट्स की हमारे पास अवेलेबिलिटी है. सो कमिंग बैक टू द हाउ कैन वी एलिमिनेट सर्वाइकल कैंसर, एंड येस इट इज़ अ प्रिवेंटेबल कैंसर. Developed nations have proven it by randomized controlled trials that if we are able to screen it and treat it at pre-invasive stage, we can successfully prevent cervical cancer. So what is the scenario of Pakistan? Pakistan has 73.8 million women aged 15 years and older who are at risk of developing cervical cancer. 80% of our women present with advanced disease. इस एडवांस्ड डिज़ीज़ के ऊपर भी मुझे बहुत सारे हमें अपने वाक़यात याद आ जाते हैं कि जब हम लेडी विलिंगडन की एमरजेंसी में जब हम दिन रात ड्यूटी पे होते, तो अगर कोई 50s 40s या 50s की एज की अगर कोई पेशेंट हैवी वेजाइनल ब्लीडिंग या PV ब्लीडिंग के साथ आती है, तो unexpectedly we find a cervical cancer which is bleeding so much that it has become a life-threatening hemorrhage or bleeding for her. Less than 1% are ever screened for cervical cancer, although screening and management of cervical is included in Sustainable Development Goals laid down by WHO. There is absolutely no HPV टेस्टिंग और वैक्सीनेशन अभी तक कोई एस्टैब्लिश्ड पॉलिसीज़ या प्रोग्राम्स नहीं हैं डेवलपिंग कंट्रीज़ में. And about 0.5% of women in the general population are estimated to harbor cervical human papilloma virus 16 and 18 infection at a given time. These are the two serotypes of HPV virus, which is an oncogenic virus, which are the main culprits and the cause behind the development of cervical cancer. 88% of invasive cervical cancers are attributed to these serotypes as well. Cervical cancer is the second most common female cancer aged 15 to 44 years. Cervical cancer is a taboo issue and it is being linked to sexual transmission. जैसे मैंने बताया, हम when we were student हम बहुत बिल्कुल cervical cancer के बारे में कोई ख़ास इतना openly ना सुनते थे लोगों को बात करते हुए और ना करते हुए. Lack of awareness and deep-seated stigma associated with the disease pose significant barriers. And carcinoma of the cervix is a neglected disease. It is truly a neglected disease in terms of advocacy, screening, prevention from professional and public health organizations. इसके निगलेक्ट होने का एक सबसे बड़ा जो सबूत है वो ये है कि हम ब्रेस्ट कैंसर प्रिवेंशन कैंपेन्स तो बहुत ज़्यादा देखते हैं अब मीडिया पर भी और हर जगह, लेकिन हम जो सेकंड मोस्ट सर्वाइकल है कैंसर विच इज़ गायनिकोलॉजिकल कैंसर, उसके बारे में हम हार्डली कोई स्क्रीनिंग प्रोग्राम्स की कोई प्रमोशंस या कोई एडवोकेसी या कोई अवेयरनेस मास लेवल पे कोई अवेयरनेस प्रोग्राम्स वी डू नॉट विटनेस दैट. These are a few of the images of the cervical cancer, which is a terrible strategy. So WHO की जो एक पूरा एक division है, which is Eastern Mediterranean Region Division, जो पूरे एक organization है, and all these countries they are included in the EMR, Eastern Mediterranean Region Division of the WHO, और Pakistan is also added in with a population of nearly 679 million people. So ये event last year October 2022 में हुआ, जिसमें कि उन्होंने ये public grant publicly announce की, और फातिमा जिन्ना मेडिकल यूनिवर्सिटी is also part of that research study to find out the prevalence of cervical cancer. अच्छा, इसमें एलिमिनेशन स्ट्रेटजी के कंपोनेंट्स क्या हैं? इस एलिमिनेशन स्ट्रेटजी के कंपोनेंट्स हैं 90 70 90. चूँकि लिखा बहुत छोटा हुआ है इसलिए इसके कंपोनेंट्स हैं 90 70 90. मीन्स 90% ह्यूमन पेपिलोमा वायरस वैक्सीनेशन कवरेज फॉर गर्ल्स बाय एज 15. 15 साल की उम्र तक 90% लड़कियों को HPV वैक्सीन की एडमिनिस्ट्रेशन कर देनी है. 70% मीन्स 70% स्क्रीनिंग कवरेज फॉर वुमेन बाय द एज 35 एंड 45. इस एज जो पीक एज है उस वक्त सारों की सर्वाइकल कैंसर स्क्रीनिंग एटलीस्ट 70% पॉपुलेशन की कवरेज हो जानी चाहिए. Cervical cancer screening program, whichever screening test we are using, either it is a cytology test or an HPV DNA test. And second 90 again is 90% treatment of cervical pre-cancer management, यानी pre-invasive disease जहाँ detect हो जाए वहाँ पे उन खवातीन की 90% खवातीन की treatment complete हो जानी चाहिए. This is the this strategy all about, और this must be completed by year 2030. यानी कि अभी 2023 7 सालों का ये प्रोजेक्ट है कि 90 70 90 ये उन्होंने एक स्ट्रैटेजी बनाई है, और प्रेवलेंस स्टडी के बाद एंड देन widespread coverage of not only the screening program but the administration of the vaccine as well, and treatment at the pre-invasive stage. सो प्रिवेंशन स्क्रीनिंग एंड मैनेजमेंट क्या है? HPV वैक्सीनेशन, जो वैक्सीन हमें पता है HPV ह्यूमन पेपिलोमा वायरस 16-18 के अगेंस्ट बाइवेलेंट वैक्सीन सर्वेरिक्स के नाम से भी है. HPV वैक्सीनेशन एडमिनिस्ट्रेशन टू एज 15 बाय एज एडोलेसेंट्स में. उसके बाद स्क्रीनिंग करें आइदर यूजिंग अ पैप स्मीयर और अ विजुअल इंस्पेक्शन और बाय एसिटिक एसिड और अ HPV टेस्ट. अगर सस्पिशियस लुकिंग सर्विक्स है देन और द स्क्रीन स्मीयर्स जो हैं वो एबनॉर्मल हैं, देन गो फॉर कॉल्पोस्कोपी सर्विसेज, लार्ज लूप एक्सीजन ट्रांसफॉर्मेशन जोन विच इज़ ट्रीटमेंट ऑफ द प्री इन्वेसिव डिजीज़. or take biopsy and then treat the disease if it is at the pre-invasive stage, and if it is an invasive stage then do stage-wise treatment, palliation in advanced stages. सो इंटीग्रेशन इज द की पहले जब ये प्रेवलेंस स्टडी हो जाए एंड दिस स्ट्रेटजी इज इन्वोल्व के वैक्सीनेशन भी कर रहे हैं और स्क्रीनिंग भी कर रहे हैं मैस लेवल पे और ट्रीटमेंट भी कर रहे हैं, तो इट शुड बी इंटीग्रेटेड विद द पब्लिक हेल्थ सर्विसेज विद इन द गवर्नमेंट हॉस्पिटल्स एज वेल. So public-private partnerships and involvement of the government to and the involvement of healthcare providers for this strategy, and situation analysis for breast and cervical cancer prevention, screening, management in Pakistan. This is this grant, and the ग्रांट के साथ जो फातिमा जिन्ना मेडिकल यूनिवर्सिटी के अलावा जो अदर NGOs and the organizations they are associated and are the Girls and Women Health Initiative and Rehnuma organization. So lot of more organizations, and the motto or the advocacy, these organizations will be used for the advocacy programs, for the awareness programs nationwide, and say no to cervical cancer, no cervical cancer no more, please join hands with us to help end cervical cancer, raise awareness, raise HPV vaccination administration, and regular screening via pap smear or visual inspection or by HPV testing. So it is a preventive campaign and prevent cervical cancer. Never doubt that a small group of thoughtful, committed citizens can change the world. And indeed, it is the only thing that ever has. And that's all by the by me right now for this campaign and this program. Thank you so much for patient listening.
Thank you, Dr. Fawzia, for a very thought-provoking talk. We will, inshallah, take up the challenge. We are a small group of people, but we will follow this motto and we will, inshallah, make a change. I will now come into the last but the most important talk of this session, जिसमें हम लोग बहुत lacking हैं, और सच्ची बात तो ये कि जिसकी मुझे भी समझ पूरी तरह नहीं आती. And it is to do a topic लेके Dr. Amreen Rauf Sajjad, because she is working in the UK system. She's been working there for several years. She has worked with the RCOG. She has developed the audit and clinical governance guidelines. तो ये जिस तरीके से हमें उसके अंदर insight दे सकेंगी वो हमारे लिए बहुत knowledge beneficial होगा. And I hope we can, with all the young associates जो हमारे पास आए हैं and who are previously working, we will be able to incorporate these things in our medical general healthcare system, but definitely in obstetrics and gynae. So a warm applause for Dr. Amreen Rauf. Madam, please come and share your thoughts.
Yes, that person go. Okay. Is it the next one? Assalamu alaikum to everybody. Thank you, Fatima Jinnah Medical University, to call me here. I myself, I'm a Chemicalian, King Edward Medical graduate, just like Dr. Aisha Malik. But I have special affiliations with this prestigious university. My mother-in-law was the first batch graduate of this medical school, and she keeps repeating how prestigious this institution is. And Mohtarma Fatima Jinnah especially came for the inauguration of this university, and my mother-in-law was the first to recite Quran-e-Pak in that ceremony. So she keeps reminding me of that. And then I have so many friends, both here and in UK, who are Fatima Jinnah graduates, and I really appreciate that everybody has invited, and they are doing so well, not only in Pakistan, but in America, in UK, everywhere in the world. So well done, girls. This was the first girls-only medical school. So well done. So I'm basically a gynecology obstetrician consultant in UK, based in Birmingham, and I think they had to give me, you can see my portfolio, so I do a lot of different roles. And regarding this audit, I'm also lead for a clinical audit. My other special interests are cervical screening and colposcopy. I'm lead for ambulatory gynecology, and I have a special interest in medical education. So I'm lead for the undergraduate medical students. I'm RCOG examiner, so quite a few different roles. Um, Yes, ambulatory gynecology, we just focus on everything done in outpatients. So, yes. So 80% of our procedures are done in outpatients. So if there's hysteroscopy to be done, that's done in the outpatient, colposcopy, loop excision treatments, all to be done in the outpatients. We can resect fibroids, remove polyps, everything in the outpatients. So that's what my role is. So today I'm going to talk about Embrace, which is reducing mortality rate through audits and confidential inquiries. So this is a triennial, 3-yearly report, which is done for mothers who die during pregnancy and up to 6 weeks of postnatal period. Previously, this was called confidential inquiry. Now the name is Embrace. So I'm presenting the latest Embrace report, which was published in September 2023, and it covered the period between 2019 and 2021. And we have to highlight that in that part, COVID played a main part in the mortality of these pregnant women. So in 2019 and 2021, 241 women died during or up to 6 weeks after pregnancy. And among these, 2,066,997 women who gave birth in the UK. So maternal mortality is in the figures of per 100,000. So in UK, 11.7 women per 100,000 died during pregnancy or up to 6 weeks after childbearing or the end of pregnancy. So what were the causes? As I said, this was the era where COVID was so prevalent, and so the main cause was COVID. And when maternal deaths due to COVID-19 are excluded, then 10.1 women per 100,000 died during pregnancy or up to 6 weeks after childbirth or the end of pregnancy. So COVID was a main culprit. 33 women out of these died due to COVID, and the percentage ratio was 14%. 33 women also died due to cardiac disease, and again, the prevalence was 14%. 33 women died due to thromboembolism, that is 14%. So in the previous inquiries, hypertensive diseases, yeah, these were the top. So we have brought them down, but then COVID came top, and then the other causes. So thromboembolism is still one of the top, and we are working on that. So 25 women died due to mental health conditions, that is 10%. One of these mortalities for mental health reasons, our trust was actually part of it. And this lady, in her postnatal period, in the antenatal period, we could not pick up her mental health disorders. She had 11 admissions postnatally, and we could not pick up her mental health issues. She committed suicide, unfortunately. So then 23 women died of sepsis, which is 10%. 22 women died of epilepsy and stroke-related illness, that is 9%. 19 women died due to other physical conditions, that is 8%. 17 women died due to bleeding. So this was 7%. So this came right down, and I'll discuss all the recommendations later. 9 women died due to preeclampsia, 4% of the women. Again, preeclampsia was used to be top. Now we brought it right down. 4 women died due to cancers in pregnancy, accounting for 2% of these deaths, and 23 women died due to other causes, that is 10%. So there have been inequalities in maternal mortality, ethnic group. So unfortunately, black people are on the top, followed by Asians. So 37.2 per 100,000 died who were black, Afro-Caribbean, Nigerian, and those sort of countries they belong to. That is 4 times. Their mortality was 4 times as compared to white ethnic group. The Asians, which included Pakistani, Indian, Sri Lankans, Bangladesh, Chinese, and others, 17.6 per 100,000, and that is twice as compared to white. And in the white, 9.7% per 100,000. So living in more deprived areas as expected, mortality was more, 17.7, that is twice if you were living in a better deprived, better areas. So the key messages from the themed morbidity inquiry report 2023 were recognition and management of bleeding. All of us know who practice obstetrics that we have to act very urgently if patient starts bleeding. The bleeding disorders can lead to clotting abnormalities and then lead to DIC and then admission to ITU, and unfortunately some of these women can die due to coagulopathies. So one of the recommendations was assess blood loss early and very regularly. Don't rely on a single bedside measurement of clotting or hemoglobin. So the lab is very important. The bedside analysis of what we call a hemoQ can be very false negative. So consider and exclude concealed bleeding. So it's not only the revealed bleeding which is important. Patient may be bleeding inside, and there might be a lot of clots in her uterus, leading to more and more PPH and bleeding. So we have to be careful about the concealed bleeding as well. Pulse rate and blood pressure are typically maintained until 30% of the circulating volume is lost. So we have to act very, very quickly. A raised pulse rate and a drop in blood pressure should prompt clinical evaluation of the blood loss. We are not good at estimating our blood loss, so we have to work on that. The national recommendation is manage operating teams for urgent and elective cesarean sections separately. So in our last CQC visit, which is to standardize the unit, whether the unit can continue or not, we failed on this. We had one team which was doing elective and urgent cesarean sections. So that team was just concentrating on the emergency sections, and the electives were delayed, and they had quite a few problems. So now most of us know what category 1 and 3 emergencies are. For category 1, you have to deliver the baby within 30 minutes. For category 2, within 60 minutes. And for category 3, they can be semi-electives. Category 4 is when you just plan a cesarean section at 38, 39 weeks, and you do it as electively. However, the teams for the two should be separate. So there should be separate obstetric team, separate anesthetist, separate midwifery team for electives and for emergency cesarean sections. More key messages were treat recently pregnant and breastfeeding women the same way as a non-pregnant person unless there's a very clear reason to do that. prepare a route for rapid delivery of advice and data on new vaccines and treatments. So all pregnant patients should be aware of what treatments she can get. Vaccines are very important because most of these patients did not have COVID vaccine at that time. Include patients in research and new medicines available. There should be equity of pregnant and breastfeeding women. Each patient should have their own tailored care according to their individual needs. We should ensure that staff in maternal medicine networks have the skills to care for the complex physical, mental, and social care needs. So all our staff, whether they are obstetricians, anesthetists, or midwives, they should be trained to look after the pregnant patient. Some more key messages were include in the guidance for admission to ECMO services. So ECMO services is extracorporeal membrane oxygen services. These are for patients who have respiratory failure. So these services are only available in big units. So we should be aware of them. It basically means oxygenation of blood and then return of that oxygenated blood to the patient. So develop training resources to promote shared decision making and counseling on medication use. So I'm just going to discuss two important causes, hemorrhage and sepsis, and what are the existing recommendations for them and what recommendations have come out of this EMBRACE report 2023. So the existing recommendations for hemorrhage are that there should be escalation of policies for periods of high activity. When everybody is very busy and there are complex cases, there should be more senior obstetric people, more anesthetic staff, and more midwifery assistants. There should be early activation of massive obstetric hemorrhage. So massive obstetric hemorrhage is when the patient loses 1.5 liters. There should be early use of fresh frozen plasma in cases of suspected coagulopathy. There should be delivery. We know that placenta creta can cause mortality. So if there's a diagnosed placenta creta, then patient should be delivered in a specialist unit which has the facilities of an interventional radiologist, a vascular surgeon, and bowel surgeon or other surgeons who can help you. There should be early involvement of the multidisciplinary team. So I'm running out of time, but I'll quickly go through this. There should be training of PPH through a multidisciplinary approach. We have team rehearsals in our hospital. So we are doing a clinical ward round and our buzzer goes off and everybody rushes to the room or place where a major obstetric hemorrhage has occurred. Responses, there should be a helicopter view when we are managing these obstetric hemorrhages. The response to obstetric hemorrhage should be tailored according to the blood loss. In case we are inducing late IUDs, there is a hormone called misoprostol, and it should be given according to the gestational age. We should be very careful about doing it if the patient has had a previous cesarean section. And for placenta creta, the delivery should be planned at 35 to 36 plus 6 weeks. More lessons are now learned were increase whenever you're doing a cesarean section for placenta previa, you should counsel the patients about the risk of lower urinary tract damage, can easily damage the ureters, risk of hysterectomy. And the elective delivery should be done by senior obstetrician, senior anesthetist, gynecologists can help, and other surgical specialties can help too. These were the existing recommendations which we are already following. So the new recommendations are elective category 4 cesarean sections should be managed separately from the urgent cases. There should be an update of coagulation tests. There should be review of guidance on what to use. We are using too many balloon tamponades
to stop the bleeding, but we do not know their proper technique. We do not know when to abandon this and move on to the next step. And specialist centers should be available to deal with these. If we have to refer them to another specialist center, they should be working day and night, and their staff should be available. Then sepsis is another cause. So existing recommendations are offer flu, pertussis, COVID-19 immunization to all pregnant women. Ensure that the care of pregnant women and the postpartum women with COVID-19 follows the RCOG and the RCM guidance. There should be urgent medical review for suspected sepsis. So if you're worried about sepsis, within 1 hour, the patient should get intravenous antibiotics. And monitoring should be multidisciplinary. There should be urgent referral to critical care team in severe sepsis. There should be urgent advice of consultant microbiologist or infectious diseases physician. Repeated presentation to general practitioners, community midwives, or to triage, antenatal day unit is a red flag. At each postnatal visit, the midwife should assess for any signs of sepsis, particularly if she's had a cesarean section. So these were the existing recommendations on sepsis. The new recommendations after this inquiry are: ensure that the pregnant and breastfeeding women get updated evidence-based advice about the benefits and risks of medication, particularly the new vaccines. There should be updated guidance on ECMO for severe acute respiratory failure. There should be specific information on referral and admission of recently pregnant women with respiratory failure to the ECMO services. These are the references. Thank you.
Just a question.
Yes.
In your routine care, are you people giving antibiotics?
No. That's why the guidance came up that we have to, if you're suspecting sepsis, just start antibiotics within 1 hour. Even if we do cesarean sections, we do not give them routine antibiotics. We just give 1 dose of intravenous antibiotic in theater, and that's all. Unless there are other things which lead us to give any antibiotic. But if sepsis is suspected, within 1 hour the patient should get antibiotics.
But how long do you keep your patient post-operative?
If sepsis is suspected,
No, if it's an ordinary case.
no, just 1 dose in theater.
And then when do you discharge the patient?
After 24 hours.
After 24. So how do you pick up the infection that is very?
The community midwife is visiting her. There are regular visits every week with the community midwife.
Every week?
Every week, yes. Thank you. Any more questions? Sorry, I had to rush a little bit. There was great pressure. But I hope that the message went through.
Thank you, Dr. Amreen, and I hope कि जब आप next time आएंगी तो we will be able to develop our guidelines according to Pakistan's situation and share them with you. और बीच में हम आपके साथ collision भी रखेंगे कि ये है because हमारी तो antibiotics आपको पता है बहुत ज़्यादा use होती हैं. So this brings us to the end of a very informative session for all of us with the best of the consultants from UK and from Pakistan who have enlightened us with their insight into subjects which are of great importance to all of us alike. Now I would request Professor Khalid Masood Gondi, who's kindly come again. It's a certificate distribution and sheet distribution.
For sheet, I would love to call Professor Muhammad Tayyab. Remote. Next is Dr. Amreen Sajjad for the sheet. She chaired today as a CAMCA UK prison.
Thank you so much.
Next is Dr. Fozia Ambar Qureshi. Please kindly come. See your sheet. Next, there will be certificates for our chief guest of today's session, Professor Shamsa Humayun. For FJ Chair, Professor Noreen Akmal. Student Chair, Dr. Muqaddas. And lastly, Professor Aisha Malik for successfully moderating and conducting this session.
चाय के बाद आज थोड़ी